Good morning, everyone. Now is the time. Welcome to the 2023 coverage for SCD Summit. This is a collaborative forum to discuss the changing landscape of healthcare for sickle cell disease. Next slide. Great. As people are trickling in here, I can introduce myself. My name is Ashley Valentine. I'm president and co-founder of Sickle. Today, we have an exciting agenda filled with opportunities to discuss the current coverage landscape of sickle cell disease, identify barriers to accessing new and innovative treatments, and build solutions together. Next slide. So Sickle is a national advocacy organization. We were founded in 2017, and we're proud to say we hired our first full-time staff in 2020. And our mission is to elevate the voices of the sickle cell disease community, to empower them, and through their voices, influence decision makers and know that the community is not alone. Next slide. Now, there's many new attendees today. This is exciting to see, and it's also really exciting to know that there's invigorated interest in sickle cell disease. For those who don't know me, my connection to sickle cell disease is my late and great brother, Marcus Valentine. Marcus lived 36 years old with sickle cell disease, and he had a vision that all his friends and family with sickle cell could receive high quality care, treatment, and live a fulfilled life just like him. Marcus received excellent care, and that was made possible by our parents. Now, in my opinion, my father is the best dad ever. But that aside, I'm going to focus on our mother. Our mom is super smart. She's an RN, she's a parent, and in our lives, she's become an expert in navigating the healthcare system. Francesca Valentine mastered navigating insurance coverage to get Marcus what he needed. Growing up, she'd miss one day of work monthly, and she'd call those her insurance days. Given the lack of data around sickle cell disease and the limited knowledge about the disease progression growing up, my mom was required to connect the dots and provide justifications for many of the stakeholders on the spectrum of healthcare. She did this to guarantee that Marcus could receive the treatment and therapies he needed to manage his sickle cell disease. During those days, she'd call insurance companies, she'd call hospitals, she called social workers, and she would create her own map of what was required and do her own cost-effective models. Whoever was involved in that coverage determination received a call from my mom that day so that she could negotiate. During these calls, she demonstrated patience, knowledge, and love, and she led with the idea people don't know what they don't know. And so today, I hope that we can make another caregiver's journey easier. We hope that through teachings today, we won't need to have monthly insurance days, and that you can take what you hear and learn and apply to the work that you do. Next slide. We have a packed day today. So following this, we'll have our keynote from Dr. Dora Hughes. We'll also have a readout of the state of Medicaid. We'll look at opportunities to improve equity and affordability in sickle cell disease. We'll also hear from panelists about what it means to advance patient-centered outcomes, and then we'll also touch on how to measure value for gene therapies. But before we get into the day, let's go over a little bit of housekeeping. Next slide. Wonderful. So we're using Whova today. You can engage during the panels through the chat function, and we'll have staff that will be monitoring the chat. Also know that this session is being recorded and that the event summary and presentation materials will be made available after the event. Next slide. Finally, I'd like to thank our sponsors for making this event possible and also being supportive of the activities that occur in the sickle cell disease community. Next slide. Now I'm honored to introduce our keynote speaker, Dr. Dora Hughes. Dr. Hughes is the Chief Medical Officer at CMS Innovation Center at the Centers for Medicare and Medicaid Services. She leads the center's work on health equity, provides clinical input on models, works with other stakeholder groups, and directs CMMI's clinician community. Previously, Dr. Hughes served as an associate research professor of health policy and management at George Washington University, where her work focused on the intersection of clinical and community health, health equity, health care quality, and workforce. You can visit Dr. Hughes' speaker bio on the event website to learn more about her past and ongoing work. Dr. Hughes, Thank you so much for being here today. I'll turn it over to you.
Thank you. I'm just so excited to join the summit. I completely agree with Ashley that where we are in this space of time, the level of attention, the awareness, the excitement, the possibilities are really, really exciting for all of us who have been working in this space for a very long time. And I also just want to congratulate Ashley and her family for what they've been able to do through their advocacy. Has really helped to make sure that sickle cell remains on the top priority list for those in the government and those in both the provider and the patient advocacy space. I was asked to speak briefly, and I do note the packed agenda that Ashley mentioned, and so I was reminded to speak briefly about some of the efforts at CMS. And for those of you that you can go to the first slide, to the next slide. For those of you who are familiar with CMS, we operate the Medicaid, the Medicare, and the Marketplace programs. About 50% of individuals with sickle cell disease are receiving care through Medicaid, and a certain proportion of them are actually eligible for both Medicaid and Medicare. So we feel a special responsibility, accountability to really think about how are we expanding access, how are we ensuring top quality of care for the beneficiaries that we are serving, again, through our Medicaid, Medicare, and to some extent, our marketplace programs. If you go to the next slide, about a year ago, our administrator, Chiquita Brooks-LaSure, and our CMS Innovation Center Director, Liz Fowler, released the strategic objectives, a 10-year vision of strategic objectives for the CMS Innovation Center. For those of you that are maybe less familiar with Innovation Center, we were created as part of the Affordable Care Act in 2010. And our charge was to support models. We call models what others might call pilots or large research demonstrations. We call them models that can improve the quality of care and reduce the cost of care. And within that high level of statutory charge, we have released our vision here for the next 10 years, a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And we have 5 pillars within that. The first being we want to make sure that all of our beneficiaries are in relationships defined by accountability for the quality of care and total cost of care. Health equity is a center point of our vision statement. I'm going to dive a little bit deeper in that in the next slide. Supporting innovation. What is the technology? What's the tools? What are the learning supports needed for providers to be successful? Addressing affordability, we have looked at that, the systems level. How are we driving down waste out of the system? But we're also increasingly looking at that from the individual beneficiary perspective. What does it mean for your wallet? What does it mean for your pocketbook in terms of out-of-pocket costs? And the final area, partnership. We're so excited to be able to partner with Sickle. We've reached out in terms of what resources can you share, what's the input, the advice that you would provide us, but so many others in this space. Partnership is just really key across all the different priority areas here for the CMS Innovation Center, or more generally for CMS. If you move to the next slide, let's see. There, within our second objective, advancing health equity, we are focused on 4 areas. The first is we develop these new models. How are we thinking about equity? What's the financing? Who should be on the care team? What are the specific interventions that need to be part of that model to make sure that we're benefiting all of the populations that we're serving? The second area is really thinking about how are we bringing in safety net providers? How are we bringing in underserved communities into our models? And being very deliberate about that being part of our core focus. The third area, evaluation, fairly straightforward. The fourth area, I think, is just the linchpin across all of these different areas. How are we collecting data, socio-demographic data, for the beneficiaries that were being served, whether that is referring to race, ethnicity, it's our socioeconomic status. What about people with disabilities? Again, we just want to make sure that we're clear on who we're serving and that we're therefore able to stratify our findings across different groups to make sure everyone's receiving top quality care. And so then if you move to the next slide, as part of our thinking about what models that we are going to be working on, as part of the charge to us about a year ago from the president to help think through what steps we can take to drive down the high cost of drugs, we have shared publicly that we are interested in continuing to explore a cell and gene therapy model for our beneficiaries of Medicaid. And you can see that in the middle row on the table on this slide. And as part of that, we know that there are a number of novel therapies that are working their way through the FDA pipeline. These therapies are curative, and they will also come with a very high price tag. So how do we make sure, again, that our beneficiaries have access, particularly our beneficiaries on Medicaid, will have access to these newer drugs that we expect to be highly effective, and they are not restricted from using these drugs because of the cost. And it's through our exploration of this model, the cell and gene therapy model, with a focus on sickle cell disease, that we are also thinking through how do we address other concerns for patients, for individuals with sickle cell. And if you move to the next slide, one example of that is addressing the social needs of our patients. All of you may be familiar with the social determinants of health, or the conditions and environments where we live, where we work, where we play. And more concretely, that can be translated into thinking about housing, thinking about transportation, utilities, food assistance, all of those which are just a critical part of the health and longevity of our patients. If you move to the next slide, through the CMS Innovation Center, we have experimented with how can we help providers screen for social needs for their patients? How can we help them refer their patients who have needs to community-based partners who can address those needs? And what impact does that have on the quality of care and the cost of care? And so this focus on social needs, we are taking the lessons that we've learned through this effort, through this work, through these earlier models, and thinking about how can we integrate this focus into our cell and gene therapy model, knowing that for individuals who may decide to take advantage of these new curative therapies, they may have transportation needs. We may have to think about the caregiver supports. They may need other assistance that will help them be viable candidates for this therapy and to actually undergo the treatment. If you move to the next slide, another example that we've heard about quite a bit through these conversations is about the behavioral health needs, the mental health needs for individuals with sickle cell. Some of that could include a focus on depression and anxiety. Some of that most certainly includes how do we think about pain management? How do we think about chronic pain, especially for these individuals? And how are we thinking through not only the types of behavioral health needs, but again, how do we think about expanding access and making sure that the behavioral health services provided are top quality? We are thinking through how we can embed that focus in our cell and gene therapy model, but also we've signaled publicly that we are working on a behavioral health model, a standalone behavioral health model that we are hoping can help to integrate behavioral health in primary care services. If you move to the next slide, another area that we're quite focused on is data. I mentioned previously that is just the linchpin across all the different areas of focus for us here at the CMS Innovation Center and other centers at CMS. And we are drilling down to think about what data do we have, what data do we need? And for the data that we do have, how can we mine that data and put that information out publicly? As example here, I would note that we have put out some fact sheets previously just for us to understand and share publicly the prevalence of individuals with sickle cell disease in our Medicaid programs as just two examples. If you move to the next slide, I always think, I like to flag if you get to a slide without a lot of words on the slide, that means these continues to be areas that we are working through. We don't necessarily have anything that we can specifically announce. But I think across all these areas, again, there's relevance for individuals with sickle cell disease. If we're thinking about maternity care, of course, individuals with sickle cell who are pregnant, desiring to become pregnant, that is a special area, a unique area of focus that we need to have. On the right, even through our dementia efforts, we focus on caregivers, especially. What supports do they need? And I think, of course, that too is another area of relevance. And then I mentioned behavioral health care, but primary care continues to be a focus. And I think that's especially important because through our primary care models, we're specifically looking at their linkages, their connections with specialists. Not just those in the behavioral health space, but it could be, in this case, specialists with expertise in sickle cell disease. How do we make sure that individuals are getting the primary care and the specialty level care that they need? So if you move to the next slide, I have to give a shout out to my colleagues in the CMS Office of Minority Health. They have just demonstrated continued leadership in helping all of us at CMS think through how can we improve access and quality of care. They have signaled publicly that they are working on a sickle cell disease action plan that we hope we'll be able to share more information about later this fall or early winter. You can see here on this slide all of the different areas that they have invested in, whether it's the data, whether it's the reporting, providing technical assistance, and thinking through different populations, whether it's in a rural community as opposed to a more urban community. I think, again, with their leadership, we will be able to realize the potential across all these different areas and really making sure that our own sickle cell disease efforts at the CMS Innovation Center, particularly through the model, are well-informed, comprehensive, and focused on the whole person needs for, again, individuals who are affected with sickle cell disease and their families. And so that, I believe, is my last slide. If you move to the next, I just wanted to end with a quote from our administrator. She said a little over a year ago that our agenda here at CMS is ambitious, but the times call for bold action. And I think working in concert with Sickle and so many other stakeholders in this community, across the public and private payers, with industry, with our researchers, that we will be able to really support the bold action that is so needed, very much overdue. And in this space, again, making sure that we are improving access, expanding the research, expanding the quality of care, with the intent of really improving health outcomes and meeting the needs of our beneficiaries. So with that, I'm going to stop. Thank you so much again for inviting me. I look forward to following up and hearing more about the discussions later today.
Wonderful. Well, thank you so much for your time. I know we have a section for questions, and if there aren't any questions from the audience, I would just like to ask one question too. When you're working with the community, do you know if CMS has a plan for how to do any sort of local community engagement or work with any of the smaller CBOs that have their events and webinars and education and training?
I'm so glad you asked that question. It's such an important question. Over this last year, for the first time at the CMS Innovation Center, we started to visit states and local areas within the states as part of, we call it a health equity tour, health equity site visits. And we were especially focused on in areas where we don't have great relationships or we don't have a strong footprint on the ground. As an example, we went to visit Lexington, Kentucky. So I say that not just the biggest cities or areas such as Boston, where we historically have very strong relationships, but trying to think through what about Minnesota? We haven't done a ton of work there. What about Texas? We haven't done a lot of work there. And so I think you're going to continue to see more of this, trying to get outside of the Washington, D.C. space and really start to go out into the states, into these other communities to make sure that we're hearing directly for those individuals, the patients, the providers, both clinical and community-based providers that are doing the hard work and can really help to inform our work here at the federal level.
Wonderful. That's really good to hear. And that's also a great demonstration of what grassroots engagement looks like. So we have time for just one more question. And the question is from the audience. When will the specifics of the cell and gene therapy model be published? And which states are participating? So one question, two parts.
Sure. And for those that have engaged, even as we're starting to explore a model, we are, I would say, beyond exploration to developing the model in earnest. There's all types of inputs that we take both from our colleagues within CMS and the other agencies that are helping to provide input. The leadership, Secretary Becerra himself, is quite interested in the model. So I say that as we're not quite at the clearance point, but we will be receiving lots and lots of input and feedback on our efforts, which will certainly, I think, make the model it'll be for the better. But because of the very rigorous clearance processes, we're hoping that we can make some high-level announcements, share more details on our intentions later this fall. Certainly by early next year, we will be able to provide more specifics. And so I know that's in many ways, it seems like a long time away. At the same time, it's also for us, it seems like it's right around the corner. But that will be more information there. We are also starting to engage quietly with certain states to understand what type of supports will they need? What would they find to be of benefit? How can we help them as they are negotiating with manufacturers to provide these drugs? And also thinking through as states, what type of wraparound services would we want to be part of the model? For example, how can we ensure that the social needs of their patients are being addressed? Or how do we think about fertility preservation? These are all open questions. It's not really clear how that will be part of the model, whether that would be something we would be able to assist on the federal level, or is that something that we would hope that states, or frankly, even the manufacturers. So trying to parse out who will do what as part of this negotiation, and what states should we be in. We certainly want states that have the capacity for negotiation, but we also want states that have significant numbers of individuals who would benefit. So it is, again, a lot of different moving parts here in terms of the conversations that we're having at the federal level, as also with the states. But we do hope within the next few months that we will be able to provide more information. And as part of that, soliciting your input and your feedback on our early plans and letting us know if you think that we're on the right path or if there's some gaps that we need to address. And honestly, how can you help us? What type of partnership opportunities are there as we seek even to increase awareness as education, as we're reaching out to different, as you mentioned, Ashley, some of the community groups to get individuals to sign up, if you will, to be interested. So we have a lot on our plate. But that being said, we're very excited, and I think we're meeting the charge of our administrator in terms of bold actions.
Wonderful. Well, that concludes our time with you. Thank you so much for presenting this morning and for speaking to the sickle cell disease community.
Thank you. Thank you so much.
Great. And so now I can introduce our Director of Advocacy. Our next session will be presented by Maggie Jalowski. In this role, Maggie works to engage with different stakeholders through outreach efforts and development of advocacy tools. She bridges her technical background in research with her health communication skills to create content that sparks a call for action for our sickle cell disease community and ensures that the patient voice is in the forefront in research, care, and health policy. Thanks, Maggie.
Thanks so much, Ashley. It's an honor to be here today. I will be sharing updates about the state of access in Medicaid. So each year, Sickle conducts an annual landscape review of Medicaid coverage policies. And we do this in hopes to provide our community with more information about the barriers and potential opportunities for access for sickle cell treatments that are currently FDA approved. Next slide, please. Through today's session, we hope that our audience will gain an understanding of the coverage landscape for sickle cell disease therapy across state Medicaid programs. We'll also be talking about some of the specifics of state Medicaid programs, what they look like, and how they differ in each state. We'll also be talking about what are the current policies on utilization controls such as prior authorization, step therapy, or opioid management for sickle cell under state Medicaid programs. Next slide. The focus of this project is within Medicaid because it's clear from our evidence that over half of the individuals living with sickle cell use Medicaid as a primary payer, which makes these programs essential to understand what access looks like for the sickle cell community. Additionally, Medicaid is particularly important for certain populations, such as low income or those adults with disabilities. Additionally, what we hear from the community of patients and providers is that they have concerns about the utilization management requirements and processes that are existing throughout these insurance companies, and they create barriers and delays in being able to receive important sickle cell treatments. So as I said, we have initiated a landscape analysis of Medicaid coverage and access policies for sickle cell therapies. And our objective for this research is to really identify where there are barriers and where there are opportunities to improve access across state Medicaid programs. I would like to note that the 2022 report from our landscape analysis is available on our website, and we can be sharing that as a resource in the chat as well for anyone who's interested in reviewing last year's summary of access. Next slide, please. Some of the important terms and definitions that we'll be using across this presentation are listed here. These are also abbreviations, so we want to make sure that our audience is comfortable with them. Specifically, I would like to highlight some of our payer-specific terms, such as PDL, which is a preferred drug list, or a list of therapies that are considered preferred across Medicaid programs. PA would stand for prior authorization, which is the authorization process that is sometimes required across insurance companies. Fee-for-service is the state-managed Medicaid program, and there are 50 state-managed fee-for-service programs in addition to District of Columbia, which is included in this analysis. Additionally, there are managed care organizations, or MCOs, that facilitate contracts for Medicaid across the states and often provide services to Medicaid beneficiaries. Throughout our analysis, we'll distinguish when we are talking about fee-for-service Medicaid programs or managed care organizations. FDA refers to the Food and Drug Administration, and we'll be talking about some of the FDA-approved therapies that are currently on the market and available for those living with sickle cell. HU is our abbreviation for hydroxyurea, which is one of the older therapies for sickle cell, and VOCs is vaso-occlusive crisis, or these pain events that individuals with sickle cell experience. Next slide, please. For this research, we contract Artia Solutions to conduct an analysis of coverage policies in 50 states and DC. In that review, we identified 5 pharmacy benefits and 1 medical benefit, and they're listed here on the chart. We have Adakveo, Droxia, Indari, Oxbryta, Cyclos, and generic hydroxyurea, which were all included in this analysis. We'd like to note that while Adakveo is listed here as a medical benefit, this can depend on the specific program, and it may differ. It may be listed as a pharmacy benefit under some state Medicaid programs. Next slide, please. So for this research, the fee-for-service programs that are included are all 50 states plus DC. And then in order to really understand how managed care plans also impact access, we gathered 7 national MCO firms operating affiliate plans across multiple states. So these plans really make up broad geographic reach and high number of lives that are enrolled in these Medicaid plans. Additionally, these policies were current as of February 2023 when we initiated this landscape review. Next slide, please. And so today I'm honored to share 10 things that we've learned about the state of access for Medicaid for sickle cell treatments. These themes highlight many of the different policies that are in place, including prior authorization, step therapy, access to preferred drug lists, the way that our stakeholders are used to improve decision-making, in addition to restrictions or exceptions that may be available for the sickle cell community. Next slide, please. So our first finding is that over half of the states do not review sickle cell as a therapeutic class on a PDL. This graphic shows the prevalence of state programs with PDL review for sickle cell treatments. This includes a total of 51 fee-for-service programs across the states, and the PDL review of a therapeutic class can help ensure that decisions related to that preferred status and other utilization controls are fair, balanced, and relevant across to clinical guidelines. So as displayed in this chart, we see that 56% of state programs do not review sickle cell treatments as part of their PDL review. And some reasons that this may be is that there may be limited cost savings available for those preferred treatments, or it may be that there is low utilization of these therapies in their state. Next slide, please. The next finding looks at the variability within states for which sickle cell treatments require prior authorization. This analysis considered all 51 fee-for-service programs across the nation and reviewed the 6 sickle cell therapies that we listed in the inclusion. So this is Adakveo, Endari, Oxbryta, hydroxyurea, Draxia, and Sickle, and they're listed on the left in that order. For this graph, the red bar indicates when there is no prior authorization required. The light pink bar indicates when prior authorization is required. And the gray bar, or the NA, indicates that there are states with pharmacy benefits being managed by managed care. So those coverage decisions do not exist within the fee-for-service program, or states without any available information about their prior authorization. So as displayed on this chart, you can see that majority of states do require prior authorization across the disease-modifying therapies, especially those ones that are more newly approved, which are the top 3 listed on this graph. So we have Adakveo, which was approved in 2019 and requires prior authorization in 37 states. Endari, which was approved in 2017, requiring prior authorization in 25 states. And Oxbryta, approved in 2019, requiring prior authorization in 31 states. However, the older therapies such as generic hydroxyurea and Draxia present the fewest barriers to access, with only 6 in 7 state policies requiring prior authorization. Sickle, which is our bottom bar graph listed here, requires prior authorization in 26 states, despite being a hydroxyurea-based therapy. I also wanted to note that, not displayed on this chart, but there are 4 states that do not require any prior authorization for any of the 6 sickle cell therapies, and those are Alabama, Delaware, New Hampshire, and North Carolina fee-for-service programs. Next slide, please. The next finding that we looked at, we are interested in learning about the standardization of prior authorization requirements across the states, and if these requirements were aligned with FDA labels for the sickle cell products. We were wondering if states had adopted various approaches to do their coverage policies, and in order to do this, Sickle identified 11 states with the highest populations of Medicaid and CHIP beneficiaries of sickle cell. In order to do this, we used the prevalence data from the 2021 Medicaid and CHIP sickle cell disease report. Our findings illustrate that there are a lack of adopted standards and coordination of requirements across these sickle cell therapies that are depicted here on the chart. So you'll see that these 11 selected states are listed in the columns, and we reviewed the prior authorization requirements for 3 disease-modifying therapies, Adakveo, Endari, and Oxbryta. Indicated by the legend, you'll see that the teal circle indicates that there are no prior authorization requirements in this state for that therapy. The orange circle indicates that prior authorization is consistent with the FDA label. The red circle indicates when prior authorization requirements are beyond the FDA label, meaning that they have a component that's more restrictive than that FDA label. And the gray circle indicates when the PA guidelines for that therapy or for that state were not available in our landscape analysis. And so as we can see that there's great variation across these 11 states, and you can also see that 6 states implement approval criteria more restrictive than FDA labels for at least one sickle cell product. We're looking at the chart, you can also see that North Carolina has no prior authorization across all 3 of these sickle cell therapies. Pennsylvania and Louisiana require prior authorization beyond the FDA label for all 3 of these therapies. And PA guidelines for all 3 therapies were unavailable for the state programs in Ohio and Illinois. Some of the examples of or reasons that we found were beyond the FDA label are highlighted in this chart to the right. And specifically what we most often saw was that the prior authorization would require a diagnosis confirmed, a specialist prescriber. Some programs, one specifically required an older age criteria than the FDA label. For example, the FDA label allowed greater than 3 years old. However, the prior authorization was individuals must be 12 years older. We also found that the trial and failure of hydroxyurea was commonly included. And then oftentimes that in order to be reauthorized for a medication, it may require demonstrating a significant benefit, such as a positive clinical response or documentation of a continued clinical benefit. So these findings demonstrate the lack of standardization across these states. Next slide, please. Our next finding highlights the lack of transparency. And so we alluded to this on our last slide, but many of the state fee-for-service programs did not have published prior authorization guidelines. And so as we see here, the red bar indicates how many state programs demonstrate that they require prior authorization for each of the 6 therapies, where the pink bar indicates how many of those programs have the published criteria available. And so we'll see that there are gaps across all 6 of these therapies, and that we were not able to identify what are the specific guidelines or approval criteria in each of these states. Next slide, please. The next finding looks at the prevalence of step therapy among fee-for-service programs. Step therapy is also often called fail-first policies, and that's the process of requiring an individual to try and fail a different therapy before another one can be covered by their insurance. Typically, the insurer uses a step therapy as a prior authorization criteria in order to require patients to try a lower cost or a generic therapy before stepping up to a more expensive one. So for this analysis, we looked at a total of 51 fee-for-service programs across the 50 states in DC. The plans excluded from this analysis were those without prior authorization, those without published criteria, those in which the medication, specifically Adakveo, was listed as a medical benefit, or those states that do not have control of pharmacy benefits, if managed care organizations have control over pharmacy benefits in those states. So from the graph, you'll see that the pink indicates those states with that have step therapy for each of these 3 sickle cell therapies. And then the gray indicates the states without sickle cell therapy. So you'll see that over 50% of the states require step therapy for Adakveo, Indari, and for Oxbryta. It's from the graph, you can see that 16 of the 23 require step for Oxbryta, that 16 of the 19 require step for Indari, and 11 of the 20 require step for Adakveo. Next slide, please. And then we hope to compare fee-for-service plans to managed care plans. And we found that managed care plans more frequently required step therapies and more frequently required multiple steps when compared to the fee-for-service programs. So this graphic is now looking at the prevalence of step therapy among those managed care organizations reviewed in the analysis. A total of 51 MCO plans were reviewed, and those were representing those 7 national MCO firms with control of pharmacy coverage across 19 states. So plans excluded from this analysis were those without prior authorization, published criteria, or those with Adakveo listed as a medical benefit. And then again, the pink indicates when there's a single step required. Now on this graph, you'll see the gold, and that's when there's a multiple step or patients are required to fail first on 2 different therapies before accessing a therapy of choice. And then the gray is that step therapy is not required for these products. And we did find, mentioned here in the box on the left, we did find that one MCO, one of the national MCOs incorporated a steep 3-step criteria and required patients to fail on 3 therapies, hydroxyurea, Indari, and Adakveo, before accessing Oxbryta. So across the board, though, across each of these 3 therapies, MCOs required step therapy more frequently than our fee-for-service programs. Next slide, please. The next part that we had looked at is specifically what were those step therapies that were used. And as our analysis revealed on the last slide, MCO plans were often requiring step protocols, not just with hydroxyurea, but with other treatments as well. And so what we found is that there were some MCO plans across the nation that incorporated a non-prescription or an over-the-counter dietary supplement of L-glutamine as a requirement before receiving Indari. And so Indari is the only FDA-approved pharmaceutical L-glutamine therapy for the treatment of sickle cell. There's no evidence to support the use of the dietary supplement for treating sickle cell or as a replacement for Indari. And so what we found is that across 11 states, there were MCO plans operating in these states that did incorporate this step of using over-the-counter L-glutamine as a dietary supplement, and really highlights the need for our community to have clear clinical guidelines or comparative studies in order to measure the safety and efficacy and enforce that as a requirement for step therapy policies. Next slide, please. Our 8th finding is that when looking at the prior authorization criteria for coverage policies, we found that there are many inconsistencies on the way that they describe the criteria for step therapy or when individuals are exempt. So this chart looks at step therapy criteria obtained for one therapy, Adakveo, and we looked across the 11 fee-for-service programs and the 5 national MCO firms and noted the variation in the number and types of criteria used across these policies. The most common criteria that we saw, and this was in all 16 of the 16 plans, was that they defined the individual must have a previous failure, which included an insufficient response to the treatment that's listed as the step. However, we also saw that some other plans offered additional criteria, such as if the patient had previously experienced intolerance or an intolerable side effect, or even if the patient was concurrently using the medication, therefore could access a new therapy in addition to the old one. We also found in this review that there were not many options for patients to be exempt from step therapy protocols within this step therapy criteria. That typically what we had observed, that the only exception criteria that was there was a contradiction, or if there was an expected AE. Only 3 of the Medicaid plans reviewed for this analysis mentioned any other clinical exceptions, such as if the provider felt that there would be a potential drug interaction. And important to note that patient preference, such as if the individual concerned one type of medication over another based on side effects or based on their daily function requirements, was not listed as a plan's criteria for exemption. And so this really demonstrates the need to establish a framework for when it's most appropriate to remove step therapy requirements or to exempt patients from step therapy in order to ensure that patients can obtain the therapies that they need at the right time. Our next slide looks at the next finding, which is looking specifically at state-specific policies regarding opioid use, and if there were any exemptions or exceptions related to patients with sickle cell. Because of the negative impact that opioid prescription guidelines have had on the sickle cell community, it's crucial that beneficiaries with sickle cell are considered for exemptions when developing opioid prescription guidelines and restrictions. There's a unique need in the attributes of individuals with sickle cell, along with continued patterns of bias, and this really creates the need for a distinct approach to establish guidelines to avoid increasing disparities in the way that individuals are able to access important pain medications. So our analysis found that nearly half of the fee-for-service programs had a specific sickle cell policy providing these exceptions to beneficiaries with sickle cell. And this really shows how strides have been taken to alleviate the nuisances of opioid prescription, and highlights the need to really exclude sickle cell, among other conditions, from the standard approach to opioid pain management. Next slide, please. And then the final results comes from our last year Medicaid review, in which we conducted a survey of Medicaid decision makers. And in this survey, we surveyed individuals across both fee-for-service and managed care plans. And our primary objective was to gain insights into what factors decision makers within Medicaid programs use or do not use when considering and determining access criteria. And what we found in this is that patients were often the least consulted stakeholder group during coverage decisions. The most common group was subcontractors, typically PBMs, to conduct and to really rely on decision making as it related to utilization management. And we found that only 8 of the 40 survey respondents sought patient input, and 11 of the 40 respondents sought community-based organization input, really demonstrating the need to have opportunities for individuals living with the disease to have their voices heard and to increase the opportunities for them to engage with Medicaid programs. Next slide, please. And so in conclusion, through this work, we really aim to provide an overview of the state of access for sickle cell therapies in Medicaid. And in doing so, we can highlight some of the current challenges and discuss how therapies can be bolstered. Our analysis found that many Medicaid beneficiaries within sickle cell are experiencing prior authorization, step therapy, and other barriers to access, and that these policies are being inconsistently used across states. These current differences across the programs can create confusions and delays for individuals and their providers, and particularly those who are coming on or off care, moving out of state, or changing their insurance plan. It is really critical for utilization management programs to be based on clinical practice guidelines and to be created with input from patients and sickle cell experts to account for the unique needs and preferences. After generations of barely any disease-specific treatments, the last few years have offered excitement as new FDA medications are approved, However, we really need to understand what is the experience of individuals trying to obtain these treatments. And we're grateful to see so many of you here today to gather with us and really understand how are we appropriately providing access to these therapies, and how can we each in our own role be more aware of the role that we can play to help this community access and afford these medications. These inconsistencies applied across utilization management can create further burdens to a group who has already faced extreme hurdles in care. And we'll be talking more about that in our next section. So we hope that this review of these Medicaid policies can help decision makers be thoughtful in finding opportunities to streamline the approach, increase transparency, and improve access. And we also hope that for any of the community members on this call, that this work can empower you all to be more engaged with state Medicaid programs and to improve patient-centric decision-making in your local areas. This report can be used to help support the use of data in advocacy efforts and help to establish local policies that can harness this data and provide better access to the community. Next slide, please. I want to note that the summaries, most of the findings that I shared today came from 2 different issue briefs that were published this summer from our Sickle team. So the first issue brief examines prior authorization for sickle cell disease therapies in state Medicaid programs. And the second issue brief looks at the variation in the use of step therapy protocols across Medicaid plans for sickle cell. And both of these are available on our website, and we'll be sharing them in the chat as a resource as well. Next slide. And so with that, I want to thank the team of authors that have been working on it with our Sickle team, specifically Emma and Mariah, who have been working behind the scenes to pull these analyses together in preparation for this report out. And then a huge thank you to our sponsors for making this work possible and for supporting our mission to improve the access and remove barriers to access for sickle cell community members. So with this, I'll remind you that we have the question, the chat feature available on your Whova platform. So please take a minute to submit any questions, and I will answer them in these last few minutes of the session. I do see one question come up here, and it says, with gene therapies on the horizon, will future state scans include information regarding out-of-state access? And I think, you know, I forgot to mention on this slide, but I do need to thank Artia, again, the contractor that we use to really compile this data for us. And so we will be working with our contractor to really understand the specifics that we need in that data pool to understand what access looks like for any new therapies, and specifically gene therapies on the horizon. And so we hope that we'll be incorporating those into the future landscape review in the following year. The next question is, does Sickle or your partners have a federal advocacy strategy given the disparities in the approach to care across Medicaid programs? And could SCD be folded into Medicare in our future, like end stage renal? In response to your first question, yes, we do. We have a robust government affairs and policy program, and specifically partner with many different stakeholders at the federal level. As we heard Dr. Hughes, our keynote, we meet with partners such as CMS and CMMI frequently to really engage them on the information that we're finding and see what they can do from their point of view. We were honored to have Dr. Hughes join us today and speak on the initiatives that they are working on across CMS at the federal level, and the collaborations then across the state lines to try and find a way to provide more consistent quality care to sickle cell. And then the second one, you know, this is a great strategy for us to look at, and it's something that we have not pursued in the past, though. I think you know, we can talk with our policy partners and think about opportunities, as we always like to use what's happening in other disease states and what has been successful to inform opportunities for the sickle cell community as well. I have another question here. What are the implications of differences in coverage policies between fee-for-service and managed care plans? And who is affected by the different plans, and how does that impact changing these policies? The first thing to note is that if you look at one state's Medicaid program, you're only looking at one state's Medicaid program. So each of these are going to be different in each state. So for example, some of the states will have only fee-for-service, where some states only really have managed care. And within those states, this fee-for-service versus managed care have different responsibilities. And so it is challenging to speak up best at the federal level without really honing in on one state to really understand the specifics. In terms of who's affected by the different plans, again, it looks at who is enrolled in either that fee-for-service or that managed care plan in that state, and in order to be who is affected by the policies. In some different disease states, we see that based on a specific diagnosis or a chronic condition, you may be automatically enrolled in a managed care plan for your state. However, in our analysis, we revealed that this was not a criteria that we found for sickle cell across any of the plans. And then based on which plan you're enrolled in would change what policies you were that were impacting you. So for example, you could be in the state of Texas, and an individual enrolled in managed care might have different policies than an individual enrolled in fee-for-service. And then the final question I see here is, did you include Indiana in your analysis? Yes, across the full landscape review, we did look at all 50 states plus DC, so 51 fee-for-service programs completely. So for this presentation, we really structured it just to highlight some of the important findings that we're seeing to be able to fit it into this session and to inform the rest of the conversations throughout the day. If you're interested in reading more specifically about the policies that we've reviewed in your states, I would encourage you to check back in September when the full report from this project is published. That will be published on the Sickle's website, and we will also be sharing it across our social media. And so you'll be able to really hone in on your state and understand some of the specifics that exist there. I see one other question here that I can get to before we move to the next session, and it's, are there efforts to address coverage differences across states? And I think this is a great place to, again, really highlight an opportunity for our community members, whether those are community-based organizations on the call or individuals living with sickle cell or their caregivers. Each of these Medicaid programs have a host committees, such as a DERB committee or a P&T committee, that helps make decisions as it relates to prior authorization, preferred drug treatments, or step therapy. And so there are opportunities for advocates to really engage with these committees to better understand the impact that they can make, and hopefully help provide some standardization across the country in referencing this data and clinical guidelines. So we do hope that there are continued efforts for our advocacy community to get involved and address these coverage differences. And then I can also note here that our ambassador program is a network of engaged advocates for the sickle cell community. Next month, we are talking about advocacy opportunities across Medicaid. So if you are interested in learning more about how you as an individual can get involved, I would encourage you to sign up for our ambassador program and join us in our next month's session to talk more about that. Great. Well, I think that's all the time I have for questions right now. Thank you all for engaging with us, and we look forward to, again, sharing more results as it comes from this work. And so with that, I'll go to the next slide. And then now we'll be opening our next session for our payer session. And I would like to introduce Terry Richardson. Terry is the Vice President of Education Strategy and Development at Impact Education. She's a healthcare leader for 20 years with demonstrated experience as managed care and healthcare experience. She is highly skilled in the healthcare industry, professional associations, and medical and pharmacy benefits, including expertise in developing utilization management, quality improvement strategies, continuing education programs like this one, and overall medical communication. So Dr. Richardson, thanks so much for being here with us today. And we look forward to having you involved in the next session.
Great, thank you, Maggie, and delighted to be here and to welcome you all to our next session entitled Opportunities to Improve Affordability and Appropriate Treatment Access for Patients with Sickle Cell Disease. Before we get started, though, I would like to take a moment to remind you all to use the Q&A and chat tab to submit any questions or comments throughout the session for our faculty. Please note that any comments posted will be seen by all participants, and we will do our best to get to everyone's questions at the end of the program. Today's session is jointly provided by Sickle, Medical Education Resources, and Impact Education, and is designated for 1.0 contact hours of continuing education credit. Please refer to the CE/CME handout available to download in the chat tab. At the conclusion of today's program, you will be prompted to complete an evaluation, which you must submit in order to receive credit. Once you complete your evaluation, you may download your certificate, or for pharmacists, you will receive instructions to submit credit to CPE Monitor. These are the learning objectives for the program today. Now we would like to start with 2 quick polling questions before we go into the program. Patients with sickle cell disease currently have a number of effective disease-modifying treatment options, and your choices here are true, false, or if you're unsure. We want to go to our next polling question. We'd like to know how confident you are in your ability to implement and/or recommend evidence-based formulary management strategies for sickle cell disease. And your choices are 6 through 1, where 6 is very confident and 1 is not confident. Great, thank you for all who participated in our pre-program polling questions. We can close the poll now. It is my honor to introduce the faculty for today's program. I will be joined by Dr. Shal Azar, Sonia Gill, Dana McCormick, and Maggie Jalowski. On the next slide, you see our agenda, which is included in the CE handout for reference. And at this time, I would like to hand it back to Maggie. Welcome back, Maggie.
Hello.
And I think you have some data and information to share with us on opening comments about the sickle cell community member and experience. And so we look forward to hearing from you.
Thank you so much, Terry. Next slide. And as Terry had mentioned, it's my honor to serve on this panel with this faculty and really bring some data forward that highlights what is the patient experience for those individuals who are living with disease. Next slide, please. So through my work as the Director of Advocacy with Sickle Cells, I've had the privilege to really meet and form such important relationships with individuals who are living with this disease, including their family members. And what we see is that this is an all-encompassing disease. And this is not just in the clinical component, but also in the day-to-day impacts of living with disease. Some of the important perspectives that need to be incorporated and really understood by stakeholders working in this space is that individuals often face stigma and racial biases throughout the healthcare spectrum, and that these considerations often impact their ability to access quality of care. Sickle cell disease not only is devastating in terms of clinical complications, but it can have limitations on the way that individuals can participate in daily life, such as fatigue and the impact of chronic pain impacts their ability to get out of the bed in the morning and participate in work or social engagements. Additionally, there's gaps in care across the community, and this results from a lack of treatments. Currently, as I reviewed in the last section, there are only 4 different types of products currently approved for sickle cell. And most of these are more newly approved. Additionally, there's a lack of specialists, and our panel today will talk more about this and the need for sickle cell specialists and quality of care across the community. I did also want to note that some of the data that looks at this has been recently captured in quality of life surveys, and specifically this one highlighted here looks at what surveys responded in terms of their personal experience. 68% of the survey respondents reported being treated unfairly when seeking care. 67% of survey respondents said that they had been treated unfairly while seeking care due to their race, and 65% of those surveyed reported feeling being treated unfairly due to requesting more pain medications. And so again, these perspectives need to be considered when thinking about coverage policies that impact individuals. Next slide, please. A really important component of this is understanding the personal stories of individuals living with the disease and those that are impacted by the disease. And so I encourage you to look at our Faces for SCD Storytelling program, where families, like the family captured here, have shared their story with our sickle cell nonprofit and offer glimpses into the realities of how sickle cell impacts the day-to-day challenges of that these individuals face. Next slide, please. And so our goal for today's session is really to talk about how care can be more patient-centered. And what we mean by this is how can we improve outcomes, decrease costs, and improve patient experience and quality of life. And in order to do this, in order to really reach patient-centered care, we need to really understand what are those outcomes that matter, that are central in providing value from the community perspective. And an important thing to note is across the outcomes that we talk about from clinical trials and coverage paperwork is that we see often there's a focus on pain events or VOCs. However, based on this survey here, 69% of patients reported managing 4 or more pain events at home in the prior 12 months. And so if there are prior authorization requirements that are mandating medically treated VOCs or VOCs treated in the hospital, there's missing a reality of these pain events that are happening at home. Next slide, please. Some of the other effects of sickle cell we want to talk about today are on patients' quality of life and overall in performance. We see that pain crises increase with age. So aging across the community is an important topic, and how individuals can age in a healthy way without pain. Additionally, we see that treatment adherence is impacted by health-related quality of life. And one survey that captured that is included on the right-hand side here, that 30% of the survey respondents reported that their insurance frequently prevents them to access important medications. And from that same survey, 40% reported that the cost of treatments prevent access to healthcare. And so when we think about treatment adherence, we really need to be thinking about these other components of impact on individuals as well. Transition from adulthood also presents an area of challenges, and often individuals have reduced access to healthcare during those times. When we talk about hospitalization, we need to also talk about other impacts such as isolation and less support that those individuals receive while in the hospital. This in another important area to talk about is overall performance and education attainment that individuals are able to achieve. This survey showed that 19.2% of children were held back at least one grade, and that 12% of individuals reported missing school. And this also can create challenges dealing with the structured school system and the policies to support absence and attendance related to reaching challenges and conforming to those policies. Next slide, please. This slide shows, again, some of the realities based on the data from recent work. And the reality is that individuals wait longer for their first dose of medication, that there's barriers to pain management, that they're not able to receive adequate pain when needed, and that warriors and families often report cost as being an important barrier to adherence. And so in order to really address and improve the care for sickle cell, we need to be addressing some of these realities and barriers that are in place. Next slide, please. And then finally, an important topic is life expectancy. While there has been improvement in the last few decades due to new treatments, life expectancy still is consistently behind healthy Americans, in addition to other rare diseases. And so it's really time to invest in treatments that will help lower and reduce this gap to improve not just quality of life, but duration of life as well. Next slide, please. And with that, I'd like to turn it over to Dr. Azar.
And actually, Maggie, before we introduce Dr. Azar, I wanted to thank you for presenting that data. And as a managed care pharmacist, we love data. And we appreciate all of the work that Sickle has done to capture the patient experience of living with sickle cell disease. I think, unfortunately, some of the results you shared are of concern around the impact of quality of life and the support that patients are receiving. But I have an expectation that Dr. Azar is going to be able to shed some light on why we might be seeing those results from the patients. So at this time, I would like to introduce our next speaker, Dr. Charlotte Azar. He is a hematologist at the Massachusetts General Hospital and Harvard Medical School, and the medical director of their Comprehensive Sickle Cell Disease Treatment Center. Welcome, Dr. Azar. We look forward to your presentation.
Thank you so much, Dr. Richardson, and thank you all for having me. It's really an honor to be on this panel and to be with all of you guys today. My hope is that in just a few minutes that we have together here, I will give you guys a 30,000-foot view of this disease that we are so passionate about taking care of every day. and talk a little bit about the treatment options that we do and do not have for this disease and why that might be. And I would ask you to try to contextualize some of the things that I'm saying in what you just heard about the quality of life and the ways by which this disease touches these patients' lives well outside the four walls of our hospital. If we go to the next slide, please. So the quick overview of this disease, that sickle cell disease is an inherited blood disorder that impacts patients in this country and around the world. And it directly leads to the breakup of our red blood cells. Our red blood cells are those cells that carry oxygen around our bodies, and it does so through a protein called hemoglobin. One half of that hemoglobin is beta globin, and it is there where the genetic error occurs that gives rise to this disease. The simple single point mutation in the beta globin gene leads to a single amino acid swap that ultimately leads to sickle cell disease. The simplicity of the genetic mutation here is important to underscore, because I want you to compare that simplicity, this mutation that we have known about for decades, to the lack of understanding that we have surrounding the disease management and treatment. Next slide, please. Sickle cell disease impacts about 100,000 people in this country alone. That number has not changed in the course of the last 3 decades because, unfortunately, it's largely made up. We are so far behind in our understanding of sickle cell disease that we don't even understand how many people are living with it in this country. And the reason for that is simple. This is a disease predominantly impacts Black and brown people. And because of the intrinsic racism within our healthcare system and medical research, we are eons behind in our understanding, to the point where we don't even know how many people are living with the disease in this country. Next slide, please. I'm a hematologist, and I take care of this disease largely because it is primarily a hematologic issue. But really and truly, sickle cell disease is an internal medicine disease because it touches every single organ in the body. A quarter of our patients will have had a stroke by the time they're 45. Many of our patients will have had their first MI in their 20s, will suffer significant lung damage in their 20s and 30s. If we do not adequately screen, our patients will become dialysis dependent due to the kidney effects of the disease. They will also lose their vision and go blind if we're not adequately screening for the impact of the disease on the eyes. And the disease has significant impacts on the bones that can lead to excruciating and severe pain. Truly, this is a disease that touches every single organ and requires a multidisciplinary approach to its management. Next slide, please. In our efforts to try to play catch up in our understanding of this illness, several national organizations have, over the course of the last few years, attempted to put forward some guidelines to allow us to better manage the disease. Because we're so far behind in our research, we have very few studies or data to actually guide us. And oftentimes we rely on the types of guidelines set by these professional organizations. The American Society of Hematology, over the course of the last few years, has been attempting to roll out guidelines specifically focused around the management of sickle cell pain, the ways that the disease touches the heart and kidneys and brain, and the way in which we use blood to manage the disease. Within the last couple of years, we've seen the first guidelines coming out around the role of stem cell transplant, which we'll talk about a little bit. Next slide. Similarly, the National Heart, Lung, and Blood Institute, as part of the National Institutes of Health, convened a panel of experts in 2014 and set guidelines at that time. Of course, that data is now a few years old, but that data allowed us to be able to have some initial guidance on how to manage the acute complications of the disease, one of the most predominant therapies, hydroxyurea, as well as blood transfusion therapy. Next slide. For some of the most up-to-date information and guidance surrounding the management of this disease, we turn to the National Alliance of Sickle Cell Centers, or NASAC. NASAC has been around for the last 3 years only, but in that short period of time, it has ballooned to over 90 recognized comprehensive sickle cell centers around the United States. For the first time ever, NASAC is leading to the definition of what a sickle cell center should provide to its patients and who a sickle cell expert should be in the management of these patients. We meet annually, all of the leaders of the 90 organizations. We met actually only about 3 weeks ago to be able to bring together our collective expertise in an effort to try to set guidelines around the management of our patients with sickle cell disease and allow them to live better lives. Next slide. So let's transition really quickly to some of the treatment options that we have available for us. And to date, the only curative option that is available for the management of sickle cell disease is the hematopoietic stem cell transplant. This therapy is a mainstay in the management of more malignant hematologic illnesses like leukemia, lymphoma, or multiple myeloma. If this is a curative intervention, why doesn't everyone with sickle cell disease undergo a stem cell transplant? As you'll hear here in a second, there are some substantial barriers that our patients with sickle cell disease have to overcome. But very quickly, a stem cell transplant is where a patient with sickle cell disease comes in, receives what we call conditioning therapy, which can include radiation and chemotherapy that ultimately wipes out their existing bone marrow. They then are rescued with the donor bone marrow from somebody else. Preferentially, that would be a sibling if they have someone who matches them. And then that new bone marrow allows them to produce stem cells that would go on to create red cells that do not sickle. Why doesn't everyone get this intervention? Well, for starters, there's a lack of compatible donors. The national guidelines highly recommend that we turn to a matched sibling donor as much as possible. And oftentimes patients will not have a matched sibling to be able to receive a donation from. So they'll have to rely on going to the national donor pool. There are not nearly enough Black and brown people in the national donor pool to afford these patients adequate matches. At the same time, sickle cell disease leads to a higher risk of graft failure than in diseases that rely on hematopoietic stem cell transplant for their treatment. That means that the donor stem cells don't take. They can ultimately fail and lead the patient back to having sickle cell disease in the first place. At baseline, there is a 4% risk of mortality, even when the patient has a perfectly matched sibling. And that risk of mortality increases the older the patient is. It's important to recognize that while stem cell transplant pushes the pause button on sickle cell disease, it does not eliminate the complications that the disease has brought with it up until that point. So if our patients go into transplant with chronic kidney disease, lung disease, heart disease, or chronic pain, all of those elements do not go away after they have gotten the transplant. Next slide, please. When we look beyond stem cell transplant to what we call disease-modifying agents, we are looking to try to target the disease in one of four main areas. These drugs look to try to target either the metabolism of the red blood cells themselves, to prevent the polymerization of hemoglobin S, leading to the sickling of the red blood cells, or to try to treat the inflammation that gives rise to vaso-occlusive events, either by targeting the disease at the blood vessels or systemically. Next slide, please. For the last 3 decades, this is all we had, hydroxyurea. When hydroxyurea came on the market in the late 90s, as per the MESH guideline, the MESH study, that study demonstrated that this drug can reduce the rate of painful vaso-occlusive events by half. But more importantly, it can improve the mortality by 40%. To date, this remains the only drug that has been demonstrated to improve the mortality of patients living with sickle cell disease. It works, we think, by raising fetal hemoglobin levels. The manner by which it does that is not completely understood, but we now recommend this medication for all patients living with SS and sickle beta 0 disease, and we use it often in patients with other subtypes of the disease who see an increase in the frequency of their painful vaso-occlusive events or end organ damage resulting from the illness. Next slide, please. Over the course of the last 5 years, we've seen 3 new drugs come out onto the market for the first time since hydroxyurea came out in the late 90s. The first of these was L-glutamine, an amino acid that serves an important role in the metabolism that our red blood cells undergo. We believe that L-glutamine works by preventing oxidative damage to the red blood cell, which ultimately gives rise to the sickling of that red blood cell and the downstream damage that's caused by that event. It was approved by the FDA in the middle of 2017. And if we can go to the next slide, you'll see that the effect of L-glutamine has been modest. It has been shown to reduce the mean rate of painful vaso-occlusive events from about 4 per year to 3. And it also seems to reduce the rate to first and second sickle cell crisis after patients have begun taking this medication. Next slide. Crizanlizumab was approved over the course of the last couple of years, and it was the first of its class to target P-selectin, an important protein that allows the red blood cells and the inflammatory cells in our body to bind to the blood vessel walls. As you can see on this table, the use of crizanlizumab reduced the median rate of painful crises significantly when compared to placebo. And it was approved in this country out of a phase 2 study because the data was so dramatic. If we go to the next slide, you can see some of that data. Where you can see that the median time to first and second vaso-occlusive crises favored crizanlizumab over placebo. Crizanlizumab is an infusional therapy, which means that patients have to come into our infusion centers and receive the medication through IV. The infusion is given every 2 weeks for the first 2 doses, and then patients have to come in every month thereafter to be able to get the medication. Next slide, please. Voxelotor was the first of its class drug aiming to raise the affinity of hemoglobin for oxygen, thereby inhibiting the polymerization of hemoglobin S in the red blood cell and hopefully reducing the amount of sickling of the red blood cells. And if you go to the next slide, you can see the impact of this drug out of the phase 3 HOPE study that ultimately led to its approval by the FDA. What you'll see in this graph, and if we click next, you can see the additional data here. Voxelotor has been shown to raise the hemoglobin levels, the total hemoglobin levels in our patients. And on average, it raises the hemoglobin level by about 1 gram per deciliter. Important to note, Voxelotor in the HOPE study did not demonstrate any impact on the rate of vaso-occlusive events in our patients. Next slide. If we look at the drugs that are coming forward in the pipeline, we are thankful that there are many. These drugs are aiming to target the disease in a handful of ways. For starters, many of these drugs are aiming to try to improve fetal hemoglobin, to try to do what hydroxyurea, we think, does, and to try to do it better and in a better tolerated manner. At the same time, there are a number of agents that are aiming to try to treat the inflammation that we think helps to induce the pain and organ damage of the disease. We're also looking to try to target the clot-forming component of this disease by looking at antiplatelet agents. And lastly, we're looking at ways that we can help to potentially reduce hemolysis, the breakdown of the red blood cells, while also potentially increasing hemoglobin levels in total, making our patients less anemic, akin to what we see Voxelotor doing. Next slide. Let's talk briefly about gene therapy because it is garnering a lot of attention in the media because it's an exciting development that we are all in the community cautiously optimistic about as it makes its way towards FDA approval. There are 2 products that are currently going through the FDA right now, and both of these products still rely on our patients undergoing a bone marrow transplant. The difference here in gene therapy versus the traditional bone marrow transplant, which I talked about a few slides ago, is that these patients do not have to rely on a donor stem cells. They can rely on their own stem cells. They give these stem cells, and then those stem cells go to the manufacturer where either they are treated with ex vivo transduction of a retroviral vector, or they are treated with CRISPR-Cas9 technology, all in an effort to try to turn on fetal hemoglobin. It's important to note that these gene therapy iterations do nothing for sickle hemoglobin. They turn on the previous hemoglobin that we all relied on when we were in the womb or in early infancy. Patients then come back into the hospital. They undergo the same myeloablative chemotherapy that we talked about before, aiming to eliminate their bone marrow, and then they receive their own genetically modified stem cells back. The benefit of this approach is that it prevents them from having to rely on immunosuppressive agents to stifle their own immune response against the foreign donor stem cells. There's no need to have to rely on a matched donor at that point. And hopefully the rates of graft failure are improved. Next slide, please. On this slide, you can see the really remarkable data that has come out from the studies that have been done on the 2 products that are about to come onto the market. And this slide specifically, you're seeing the data from Lovocell, the product that was created by Bluebird Bio. And on the left side of your screen, you'll see both the red squares and blue squares, which are representing the number of vaso-occlusive events that patients faced prior to undergoing treatment. And then on the right side of the screen, they're separated by that black line, you'll see the number of vaso-occlusive events after treatment. It's remarkable. What's really important to emphasize here is that this is not a curative therapy. As I mentioned in the last slide, patients who undergo this intervention are having fetal hemoglobin turned back on. They still will have sickle cell disease, but the hope is that the rates of crises that they face and the rates of end organ damage and other complications from the disease will be mitigated significantly by the gene therapy intervention. Next slide, please. Lastly here, I just wanted to emphasize this project, that a core engagement project that was done, defining the value and supporting equity in sickle cell disease. The purpose of this project was to establish action items for research and value assessments to capture the cost and the burdens that matter most to our patients. I've gone very quickly to the treatments here that our patients have available to them. But as I mentioned at the beginning, it's important that we contextualize these treatments in the way by which our patients live their lives. It is the work that all of us who care for these patients do when we are sitting with our patients in clinic every day. And with that, let me turn it back to Dr. Richardson.
Great. Thank you, Dr. Azar. That was a wonderful overview of the current treatment options. And also thank you for highlighting some of the gaps that we have and providing some insights on the innovations under development for patients. We are going to come back to that equity discussion that you mentioned at the end with all of our panelists. So we'll come back and talk a little bit more about that in a couple of minutes. But next, we would like to hear our payer perspectives on sickle cell disease. And we have two speakers, Dana McCormick and Sonia Gill. Dana currently serves as the Director of Pharmacy at Blue Cross Blue Shield of Texas, where she oversees clinical account consulting and account management services. And Sonia is currently a clinical pharmacist in drug information and pipeline services at Centene. Welcome to you both.
Hey, thanks so much. Appreciate it, Terry. We can go to the next slide. I'm going to start out real quickly, just giving some high-level coverage statistics, and then we're going to talk a little bit more with Sonia about the development of utilization management programs and some of the things that go into that decision-making process. But here real quick, just to level set with kind of the patients and the insurance coverage and types that they're coming from. This is a report that the Institute for Clinical and Economic Review produced in 2021. They started the work in 2020, and they were really looking at the effectiveness and value of certain products that Sonia is going to talk about a little bit. But one of the things they did is do a little demographic work, working with the Sick Cells and the Sickle Cell Disease Association of America, and they did an online survey. And it was a part of the way they assess products and the value that they provide to help kind of quantify information on the quality of life and productivity that the disease and certain treatments, how treatments can help improve that. So anyway, this is just a quick overview of kind of the health insurance status that's probably pretty representative across the country. But we can see here that the respondents are, primarily covered through commercial insurance, either through work or school or their parents or through state exchanges. And then also we had about a third of the patients were covered by Medicaid and about 19% were covered by Medicare. We can go to the next slide. So Maggie did go over a lot more detailed information, but I just kind of want to refresh everybody with a high-level overview that'll help kind of set up our panel discussion in a few minutes. But this is just a review of access for sickle cell disease treatments. And we've broken it up under those that are under the pharmacy benefit and those that are covered under the medical benefit. And we can see here that for the pharmacy benefit, just to call out a couple of numbers, about 44% of the lives under commercial formularies are covered and do have some kind of utilization management restrictions in place. And about 37% of Medicare formularies actually do not show coverage for at least one of the agents that is currently available. Then if we look at the medical benefit, we see where crizanlizumab is covered. And again, as Dr. Azar was talking about the fact that it's an infused medication, it typically is covered under the medical benefit since it requires professional administration. And we see here that about 67% of the lives that were under commercial policies have some kind of utilization management restrictions, and about 69% of lives under Medicare policies have access without any kind of utilization management criteria. We go to the next slide. And here's a deeper dive into kind of looking at specific policies, whether it be step therapy or prior authorization policies, and identifying kind of what is restrictive or provides less coverage than what's required or what's written in the FDA label. So we see here for about 79% of covered lives, pharmacy benefit formularies do not require step therapy. And of those lives that require step therapy, about 22% require multiple steps. And I think Maggie talked a little bit about that earlier. And then around 56% of payer-controlled pharmacy benefit covered lives require prior authorization, and about a little over half of those lives are covered by policies that are more restrictive than the FDA-approved label. We go to the next slide. So this is actually data from a Sickle's recent publication, Medicaid Access and Landscape Review. And we can see here what this is taking a look at is the use by state Medicaid programs and Medicaid MCOs about, again, the reason that they put utilization management programs in place is to ensure that, patients get the clinically appropriate therapy, but then also do use it as a cost saving strategy as well. And this kind of reflects that, UM really does vary across the therapies, and there isn't a lot of consistency, but the prevalence of prior authorization and step therapy as the two main drivers of management in this class of drugs or in these drugs is really a key theme. So if you look at across all payers, whether it be fee for service, Medicaid, managed care Medicaid, that they are really requiring prior authorization and step therapy over half the time as a predominant way that they're managing it. So I think I'm going to turn it over to Sonia, and she's going to talk a little bit about, go a little more detail into ICER and talk about some other insights that we hope payers will use to guide policy decisions. So Sonia.
Thank you, Dana. I just wanted to first briefly say it's an honor to be presenting with such esteemed experts in sickle cell disease. So thank you for having me here too. So I'll first start with going briefly over this ICER reports for sickle cell disease and get into some utilization management practices. So 2019, ICER released their sickle cell disease review of the 3 agents that Dr. Azar discussed, looking at the evidence ratings, the treatment effects, and long-term cost effectiveness of these 3 therapies with different mechanisms of action. And we see they provided evidence ratings of a B+ for crizanlizumab and a promising but inconclusive for voxelotor and L-glutamine, and that voxelotor score ties in with the lack of VOC or vaso-occlusive crises improvement, but they did have the change in hemoglobin. And L-glutamine, there were some questions around the clinical efficacy, the dropout rates in the trials. And we see here also the relative effect on acute pain crises being presented. They were used as inputs into the cost effectiveness model. And in the last column, we see the modified societal perspective cost per quality, or the economic value of lifetime productivity. So that's like caregiver burden, missed school and work, the lifetime productivity gains from treatment compared to usual care alone. Here, Endari seems to stand out at $289,000. So that cost per quality of L-glutamine or Endari was affected the most because the productivity gain was substantial compared to the cost of the treatment, which is significantly less than the other 2 agents. ICER also attempted to quantify the treatment's ability to reduce the racial disparity in life expectancy, since economic models can't really capture the full impact of systemic issues like racism that may impact underserved populations like patients with sickle cell disease. So they compared the life expectancy of patients with sickle cell disease in the model to the life expectancy of a matched non-sickle cell disease population and to the general population. And their model estimated that treatment with either crizanlizumab or voxelotor would reduce the racial disparity in life expectancy from 45% to 40%, and treatment with L-glutamine would reduce that disparity to 42.5%. So here we can see the potential impact, the potential improved outcomes with these therapies. Next slide, please. More recently, ICER released their sickle cell disease gene therapy evidence report this year. So in the short term, they found that both lovo-cel and exa-cel, the two gene therapies in review now by the FDA, can dramatically reduce the frequency of painful crises in patients with severe sickle cell disease. And long-term efficacy and safety have important uncertainties, particularly for exa-cel, the first CRISPR therapy to apply for FDA approval. Up till now, we've seen viral vector gene therapies like lentiviral and adenoviral vector therapies. Going into that long-term efficacy and safety and uncertainties, they go on to talk about considering the small population studied along with the potentially severe harms of myeloablative conditioning that Dr. Azar discussed in sickle cell disease, and uncertainties about the duration of benefit that should be considered when looking at the net health benefit. And it's also not known whether the results from the trial will generalize to a broader population of people with sickle cell disease who might not have otherwise met the eligibility criteria. Current evidence suggests that the lovo-cel and exa-cel would achieve common thresholds for cost effectiveness with a health benefit benchmark price of 1.35 to 2.05 million. And lovo-cel and exa-cel manufacturers haven't announced the prices yet. They tend not to announce them until after approval, but both do have FDA PDUFA dates or decisions from the FDA set for this December. So we should see this shortly if approved. And more recently, in the last week, there were voting results on the clinical effectiveness and contextual considerations for the gene therapies. And there was a near unanimous vote that current evidence is adequate to demonstrate a net health benefit for both lovo-cel and exa-cel when compared to standard of care. That would be hydroxyurea, your chronic blood transfusions, pain meds, iron chelation. And the panel did unanimously vote that the current evidence isn't adequate to distinguish the net health benefit between the two. Next slide, please. AMCP Market Insights did release a report on optimizing the management of inherited blood disorders, including sickle cell disease. So they identified significant challenges and drivers for sickle cell. So within the significant challenges remaining in sickle cell care, they cited the lack of effective disease-modifying treatments. And this is also probably highlighted by Adakveo crizanlizumab recently had a STAND trial looking at the benefits in VOC, and they found that there wasn't a statistically significant reduction in VOCs with Adakveo crizanlizumab. So that's being discussed with the FDA on next steps. But in Europe, the auth has been revoked for Adakveo and sickle cell disease. Also, the lack of centers of excellence across the US for adults, the transitions from pediatric to adult care. Patients often receive care from generalists and ER docs who aren't quite equipped to deal with sickle cell disease or don't aren't aware of the stigmas around it. And then there's discrimination, uninformed clinicians, and stigma around the need for chronic pain management. And then there's impact on the daily life, such as disruption of family and social activities, missed activities like school and work. And looking at drivers for new drug development in sickle cell disease, the report did cite the monogenic disorder caused by the variation in a single gene. So that beta globin gene can would make a very attractive target for gene therapy. The current lack of effective DMTs, recurrent VOCs, and being linked to younger age of death among individuals with those high rates. And lastly, panelists did highlight the lack of investment in sickle cell disease research, which is out of step with societal investment in managing other inherited blood disorders. Looking at, for example, in a recent JAMA study, disparities in funding exist between sickle cell disease and cystic fibrosis. They are both inherited disorders that result in intermittent disease exacerbations requiring hospitalization, but they are also associated with a substantial reduction in median lifespan. And looking at the funding, cystic fibrosis received around 3 times higher funding from NIH versus sickle cell disease. And looking at philanthropic funding, cystic fibrosis received about 75 times higher funding than sickle cell disease. So we see that disparity highlighted there too. Next slide, please. So this slide highlights the extent and financial impact of VOCs or vaso-occlusive crises with increased ED visits and hospitalizations, where patients with sickle cell disease are 7 to 30 times more likely to be hospitalized than Black patients without sickle cell disease, and 2 to 6 times more likely to visit an ED compared to Black patients without sickle cell disease. So these ED and inpatient treatment costs for sickle cell patients are approximately $3 billion per year in the United States. And this is not considering other economic costs, such as childcare and work and quality of life impact. Next slide, please. When it comes to these therapies, though they'll likely be initially used by a small portion of the sickle cell community, it will still be important for the states and managed care organizations to ensure access by defining criteria and considering how they will finance these therapies. So states are beginning to address this role in future decision-making. And state programs and MCOs are preparing for cell and gene therapies by discussing and creating and considering coverage policies and criteria. For Centene, this looks like beginning policy work prior to FDA approval and the creation of preemptive policy. So the discussions are begun early. Looking at value-based contracts. For Centene, we currently have a couple of VBCs or value-based contracts in place and are in discussions regarding several other gene therapies. These are helpful in also mitigating the cost of therapy, specifically in the instances of failures or potential failures. And then lastly, specific drug carve-outs from MCO contracts. Many plans begin these discussions early with their state Medicaid agencies regarding carve-outs, specifically in the case of high-cost gene therapies. And now I will hand it off back to Dana. Thank you.
Yeah. Thanks so much, Sonia. So again, just real briefly, again, and we'll hopefully get into more, you can go to the next slide, the more detailed discussion around this during our panel discussion. But again, the real goal in any kind of utilization management program that is put into place by a payer, whether it be a government entity or commercial, private, would be to ensure that we are not unnecessarily creating barriers to access for patients that need those medications. And so again, there's a lot of different things that as we're highlighting, and there's a lot more information coming out about kind of quantifying health disparities in certain disease states among certain patient populations, making sure that we're including those kinds of discussions as a part of the process is super, super important. And there are different, we go to the next slide, actually. There are more, there are certain tools now that are being recommended and resources to help have really intentional discussions around how do you design coverage policies and coverage in general, copay and benefit designs, so that we are addressing health disparities in across our patient populations. But Terry, we'll dive into a lot more of that here, hopefully in the next couple of minutes. But Terry, I'm gonna turn it back over to you so we can start our panel discussion.
Great. Thank you both for walking us through some more great data on the current access and treatment options for patients with sickle cell disease. Dr. Azar, I want to start our panel discussion with you and go back to what you briefly touched on, and really thinking about, your clinical experience of working with patients and the work you do to advocate for underserved patient populations. What opportunities do you see in addressing and reducing health inequities for patients with sickle cell disease? And specifically, is there anything that we should be thinking about as relates to access to treatments?
That's a great question, Dr. Richardson. Thank you. I view the ultimate way to change, to move the needle in sickle cell disease as a top-down approach. Other chronic congenital diseases, like Sonia mentioned, cystic fibrosis or hemophilia, another disease that I as a hematologist manage. These are disease processes that are very similar in the needs for their patients to be hospitalized. But yet hemophilia, for example, receives federal funding, and the federal government sets a standard by which these centers get to call themselves a center, and then provides them with the funding to provide resources and help to cover the costs of the medications for their patients. We have nothing that resembles that in sickle cell disease. I feel excited about the fact that there are currently new pushes in the political realm to try to help remedy that. We here in Massachusetts, for example, have introduced our own bill that will attempt to level the playing field, and there are several other states around the country that are doing something similar. Ultimately, to be able to carry care similarly across the whole country, we need a federal bill. And there is a federal bill that has been introduced before the Congress. We are all advocating voraciously to try to get that through.
Great, thank you. Definitely some actions that can be taking place, both state at a plan level and then nationally to address some of these inequities. So Dana, Sonia, I want to, if you can go to the next slide, I want to talk a little bit about how P&T committee decisions are made and some of the economics. And we have some questions actually that we'll get to here at the end from our audience. But can you just quickly tell us how payers are looking at or thinking about the impact of patient out-of-pocket expenditures and some of the indirect costs that Maggie highlighted as important to patients when payers are looking at, clinical evidence development and policy development?
Yeah, I can start off. I think from a commercial payer's perspective, one of the things when we have rare diseases is there's a lot of time a lack of understanding and knowledge about some of the indirect costs, like how is it impacting work and productivity and presenteeism and those kinds of things. So, and as Dr. Azar mentioned a minute ago, like we're really kind of unsure about the patient population overall, just in general. So we don't have a lot of good data. But the more we can kind of generate that information, I know it is definitely something, if there's data available that is considered by commercial payers about the impact of therapies on other aspects of a patient's quality of life, and also just their, caregivers that are potentially caring for patients, and then also all of the aspects of a patient's life as it relates to being able to manage, that disease. But we just don't have a lot of data.
Sonia, do you have anything to add when you're looking at the evidence for treatments as it relates to the impact on the patient from a financial standpoint?
Not a lot more to add than what Dana said, but looking at like opportunities for payers to look at the economic impact on patients differently. So as we saw with the presentation, gene therapy seemed to dramatically reduce VOCs and hence the downstream consequences that come from VOCs and taking care and its impact on quality of life. So improving access to potentially these therapies would be instrumental in ensuring drug policies are fair and evidence-based to make sure that patients who need it are able to get it at the P&T level. From a general payer perspective, I can see the benefit of programs, clinical and patient care to assist with things upstream that will help with out-of-pocket costs and other costs to patients, like assisting with things such as transportation, caregiver support, since many patients are caring for children who may miss school. Access to appropriate care to improve adequate treatment is being offered, which would all ideally improve the overall sickle cell care and help limit the cost burden on patients.
Yeah. And
yeah.
to that,
oh, go ahead, Dana.
I was going to say, just to add on to that, I do feel like from a commercial payer's perspective, it is really important for us to work with our employers who are the ones responsible for, setting their benefits up and helping them think through how their benefits may put financial burdens or access barriers to their patients that really need treatment in order to reduce, overall healthcare costs and improve outcomes. So it really is up to us to help our employers understand the decisions that they're making and how they're setting their benefits up so that all of these barriers can be reduced.
Yeah, a great point. And we need to make sure that we have all the right stakeholders involved in addressing some of the financial burdens. Several of you, I think all of you actually have mentioned the caregiver, the patient and the caregiver. And Dr. Azar, I wanted to get your thoughts on, what are the opportunities to better support the sickle cell disease community, both the patient and the caregiver when it comes to mental health?
Oh, that's such an important topic. And I really am, I'm so thankful that you brought it up. This disease, I always describe that we think about this disease as primarily leading to pain, but I describe it more as sickle cell suffering rather than sickle cell pain, because I think that I view it as sort of a tangled knot of the very real physical pain that our patients experience, coupled with the existential suffering, the mental suffering, the psychosocial suffering that comes from living with a chronic congenital illness their entire lives and having to rely so much on a healthcare system that has so few resources to be able to give them. At our center, for example, we aim to invest a lot of resources into helping our patients actually get to clinic. We provide resources towards transportation, towards food insecurity and housing insecurity. All of these are important barriers. I always talk about the fact that I cannot put hydroxyurea into the mouth of a patient unless I can put food in their mouth first. And unfortunately, there are not nearly enough resources available for us to tap into. All of the resources our center is able to offer is entirely the result of philanthropic donations. But being able to get our patients to the clinic relies on making sure that their lives outside of the clinic are stable.
Yeah, it's a really important point, and great that you guys are looking at alternative ways of funding the support that you've identified are needed for those patients. I have one last question for our panelists, and then I want to make sure we get to our audience questions because we have several of those coming in. But I'm going to ask each of you, well, we heard a little bit of different perspectives on the view of success in terms of treatment with disease-modifying therapies throughout the last 50 minutes. So if each of you can maybe give me one opportunity that, from your perspective that you see to improve access to disease-modifying treatments for patients with sickle cell disease, and who you think needs to be involved to make that difference. And Sonia, I'm going to start with you, and then maybe Dr. Azar and Dana, you can provide your thoughts on how do we improve access to care for patients.
Yeah, for one, just one way. Okay, so I know there's several that we've talked about, but from a payer perspective, I think identifying providers managing sickle cell patients and offering education on sickle cell disease management, it looks like an oft-cited reason, but with a lot of sickle cell patients is just stigma around their disease, going into the doctor, seeking pain management for their disease. So offering those PCPs and other providers education on sickle cell management, I think would help bring more patients maybe into the office.
Great. Dr. Azar, what is your one opportunity you think that we should walk away with?
I think the one thing that would be most useful is to be able to make it easier for our patients to have access to their pain medications. We've talked a lot about the disease-modifying agents here, but it is a constant burden to be able to get our patients access to their pain medications.
Okay, great point. And Dana?
I'd say like maybe a more holistic approach to how a patient living with sickle cell disease is being has access. So not just to the disease modifying therapy, but to pain medicine, to mental health benefits. Then also I think one of the questions is around, about access to limb treatment. So again, maybe a more overarching holistic approach to how a patient, like what are the different things that a patient with sickle cell disease may end up with needing services, and how can we ensure services are available across the board, not just in the one area for the disease modifying treatment itself.
Right. Yeah, definitely taking that holistic and patient-centered approach, I think, are good options for us. So we have about 3 minutes left, and we have had several audience questions come in, so I'm going to get to those. Sonia, I'm going to give you, I think, which will be a nice, easy one to kick us off. So we have some audience members wanting to understand how payers decide if drugs are covered under the pharmacy versus medical benefit, and then where they can find information about prior authorization and step therapy.
So pharmacy versus medical benefit, generally, if you can pick them up from a pharmacy, orally administered medications, you'll see those under the pharmacy benefit. If they're infused or injected in a doctor's office, they're typically under the medical benefit. As far as finding information, are you talking about from a patient perspective or?
Yeah, I think it's more about the criteria for coverage. Are those available anywhere that patients could find it, or physicians if they're looking at that?
Yeah, I think often companies have, or managed care companies have, physician portals and patient portals to look at their formulary lists, and often a link or something there to look into the prior auth criteria or the clinical policies for those drugs. So it should be available to those patients and providers within those managed care organizations and payers.
Okay, great. And then Dana, here, one for you. Maybe not quite as easy and straightforward, but how are payers thinking about authorization when it comes to patients who might be outside of a network, as we are hopefully moving towards having some gene therapy treatment options for patients? Are you guys starting to think about that, or are we still waiting for FDA approval?
No, absolutely. So again, as we think about even the current gene therapies that are out, and having a limited number of qualified facilities that are able to administer those kinds of treatments, it is something that we've been working on and have been actively engaged in, as we have patients that are receiving those kinds of treatments. So I think everyone pretty much handles most of these cases as single cases. And so they pretty much kind of always reside outside of the normal process. Now, to the question about how can we help make sure that there's not, an excessive amount of time that's needed, that's something that I think we can all still work on. But again, becoming more common and processes built around that.
Great, thank you. So I think our last question here, is we're almost at time. Dr. Azar, I'm going to start with you, but Dana and Sonia, I definitely want you guys to add your thoughts at the end as well. I'd like to just end, in a positive, forward-looking perspective, and like to understand what you're most excited about in the treatment options or the care of patients with sickle cell disease going forward.
I think very quickly, I'm just excited about the fact that our healthcare system is finally looking at this disease, and that panels and conversations like the one we're having here are actually finally taking place.
Dana or Sonia, do you have anything to add?
I would probably just say I'm really excited to see the outcome of these gene therapies and how the durability of their effect. And I know, like Dr. Azar said, it's not a cure, but elimination of those VOCs would just be an amazing thing for patients with sickle cell disease.
And I just say, like, the more therapies we have come out, the more it shows that we're understanding the disease and being able to make and tweak future therapies to really provide positive outcomes for patients.
Great. Well, I thank you all for that discussion and for the questions from our audience. I think we really heard that this increase in availability of treatment options for sickle cell disease is welcomed. But there are still some ongoing disparities in care that we need to address as a healthcare system. And we are looking to multi-stakeholder approaches to help mitigate some of these barriers and ensure that patients with sickle cell disease receive adequate coverage and care that they need. Our faculty have given us several recommendations to consider and some positive opportunities to look forward to in the near future around improving equity and access to care. I would now like to thank them all for their excellent presentation and insightful commentary. And I once again would like to thank Sickle for their support of this program. Your feedback is important to us, and to remind you to complete the CE and CME evaluation form to claim your credit, please select the link that is shown in the chat tab now. Once you fill out your evaluation certificate, it will be emailed to you, or for pharmacists, you will be provided with instructions to make your CPE monitor, just to submit to CPE monitor. I want to thank you all again for participating, and we will now take a 10-minute break. Thank you.
Hello, and welcome back from our break. Our next session is titled Quality Data Efforts to Advance Patient-Centered Outcomes. This will be a moderated discussion, and I'm honored to introduce Dr. Latasha Lee, who is the Director of Policy and Alliance Development at Vertex Pharmaceuticals. In this role, Dr. Lee leads U.S. patient advocacy for diseases and conditions such as sickle cell and beta thalassemia, and is responsible for developing and executing the broader alliance strategy at Vertex. Prior to joining the private sector, she previously worked at healthcare-focused nonprofit organizations with roles at the National Minority Quality Forum and the American Society of Hematology. Tasha, we're honored to have you here join us today, and thank you again to Vertex for being our gold sponsor for this event.
Thank you, Maggie, for the introduction. And I really would like to just share that Vertex is so proud to be a sponsor of this year's summit, as well as share with you our commitment to the sickle cell community by working with the community and not just for the community. So for those of you who are unfamiliar with Vertex, we are a global biopharmaceutical biotechnology company that invests in scientific innovation to create transformative treatments for individuals with various serious diseases, including sickle cell disease. At our company, you will find that we are what we call serial innovators, and pride ourselves in putting the patient first, as that they are at the heart of all that we do, and addressing the cause and not just the symptoms of disease. You will find that we try to make transformative changes in individuals' lives, and it's evidenced by our slogan that we are not afraid to take on the impossible. For today's session, I'll be joined by 4 other individuals shown on today's slide. It is my honor to introduce each of them to you. The first is Jasmine Hightower, MSW. She is a patient advocate, and Jasmine is from Dothan, Alabama, and she's a native there. She graduated from Dothan High School in the class of 2009. After graduating, she attended Stillman College and received a bachelor's degree in psychology, and then became a AmeriCorps member, where she was inspired to pursue her master's degree in social work to help her community. Today, she focuses her passion and is very active in the rare disease community, and is both an advocate and a lobbyist. Followed by Jasmine, we have Paris Magruder, who is also a patient advocate. Paris is a rare disease advocate, museum studies graduate, and a person living with sickle cell disease. She currently works at the Cystic Fibrosis Foundation as a training and operations senior specialist, and is entering her 2nd year as a Sickle Cell ambassador. Next, Dr. Joe Michael Fusco, PharmD. Dr. Fusco currently acts as the MCO Pharmacy Compliance Manager at the Virginia Department of Medical Assistance Services and Virginia's Medicaid program. After receiving his PharmD from West Virginia University, he began his career in the Medicaid space as Assistant Director of the West Virginia University School of Pharmacy Rational Drug Therapy Program, assisting in the state Medicaid program in West Virginia with formulary management. After 6 years of program development and consultative services, he moved to his current state government role within the Commonwealth of Virginia. And he looks forward to discussing the importance of data to make informed decisions to optimize outcomes for sickle cell care. And last but not least, Luis Cabanella, MSc. Luis is an analytic strategist with a career that spans both payer, provider, pharma, and policy positions. Over the past 6 years, he's designed and implemented population health and health equity solutions to improve data ergonomics and better allocate time as well as resources. Through collaboration with academic and thought leaders, he has developed continuous improvement processes to characterize populations, analyze drivers of poor outcomes, create algorithms to match members to interventions, and measure the impacts of those interventions. Most recently, he and his team have developed a composite social inequality index for members, leveraging geospatial analytics to enable data-driven health equity strategy. He has a special interest in addressing health literacy in marginalized communities and improving preventative care. He received his MSc in health economics from Erasmus University in Rotterdam, the Netherlands, and a BA in economics from the University of Colorado Boulder. So for today's session, not only do we talk about data, but the overarching goal is to discuss the use and accurate and high quality data to capture the needs, health outcomes, and disparities experienced across the sickle cell disease population. Each of the panelists can offer this very different and diverse experience and perspectives to help us understand the value of such data efforts and also share with examples of data collection efforts that are being used to inform coverage decisions. By the end of the session, we really hope that you'll be able to identify solutions to leverage social determinants and health data and other patient-reported outcomes in the health sector. So I'd like to actually start with some opening remarks by each of our panelists, if we could come on camera. As we heard in an earlier session, sickle cell disease can present a substantial challenge to the managed care and payer professional community. There are various unmet educational needs, and payers are often tasked with weighing considerations of efficacy and cost while balancing formulary placement, prior authorization, as well as step therapy in implementing optimal drug management initiatives. To kick off the conversations, each of you, I'd like you to share your perspective and expertise on how high quality data can help address many of these challenges and why it is important to ensure robust data is available for the sickle cell disease community. Let's actually first start with Lewis.
Well, it's good to be here, and thank you for having me. I think for me, coming from the population health view, we try to think more broadly across the entire population. And so there's considerations and there's characteristics about sickle cell that are similar to other conditions, and there's things that are unique, which I heard a lot of that today when the experts previously talked. So the goal for population health a lot of time is the best allocation of resources. If you don't have the right data, you don't know what's the most efficient way to use that data, or the most efficient way to allocate resources to try to help maximize the impact of what you're doing. So understanding the entire member for mental health needs, physical needs, social health needs, all that is important to have like the right data to make the right decisions and kind of maximize the impact of the resources.
Thank you. Next, Jasmine, would you like to share your perspectives on why data is important?
Can you repeat that? I'm sorry, I couldn't hear you.
Sure. Would you like to share your perspective on why data is important for the sickle cell disease community?
Yes. So one of the biggest things that I feel like why it's important is because right about now we don't know how many people actually have sickle cell. We have a estimated guess about it, but we don't have an accurate number. And when you don't have an accurate number for things, it is no way you can possibly know what to do for everybody with that disease. If you don't have a number, you don't have the funding for it, and that comes with a lot of things. And yeah, for me, that is one of the things. And then also, yeah, that I'll leave it right there.
I think that's an important one. And so thanks so much for that, Jasmine, because you can't put resources and allocate and create policies accordingly if you don't know where the patient population is. So next we'll go to Joe Michael.
Hey, thank you so much for having me. I think data is so important, especially, here in Virginia, we're a managed care state. Our Medicaid program is managed care. And so we essentially have 5 different programs. And with 5 different programs means 5 sets of data, 5 different standards of care. We try to make sure they're as consistent as possible. But being on the government side of things, it's very important for us to have an accurate look at that data so we can make sure that we are giving our MCOs, or our MCOs are providing the appropriate resources. And then, of course, data accuracy becomes, an issue as well. Everybody collects data differently. Everybody uses different methods. So just making sure we have a consistent view and we have a good hold. We can't make decisions, as Jasmine said, if we don't know who we're making decisions for, or how many people, how much resources we have to allocate for those individuals. You're kind of destined to failure if you don't start with those important data points.
Thank you. Last but not least, Paris. Oh, Jasmine, you want to come back and piggyback off that?
Go ahead. I'll let you go ahead. It's fine.
Please feel free.
No, it's totally fine.
Okay.
Just go, you go ahead.
Thank you. And thank you, Tasha. So happy to be here. Yeah, so for me, ensuring robust and accurate data for the sickle cell community is so important because it enables personalized care and improves outcomes and drives research advancements. In my experience as a person with sickle cell disease, having met other people with sickle cell, our experiences can be very similar and also totally different. In a clinical setting, we might be asked similar questions in reference to like our pain levels, frequency of crises, and overall wellness, but there's so much more information to gather that isn't typically gathered. I guess I could just speak to my experience, like with the issue I face with insurance is that I'm rarely hospitalized and I see my sickle cell care center like once or twice a year. But when I do have a complication, it's rare, but doesn't mean that I'm not affected by sickle cell disease in other areas of my life. So my experience isn't reflective of a person who has multiple hospitalizations in a year and is highly visible in the healthcare sector. So I think it's important for payers to be able to capture the full data analytics of the sickle cell community. While there are some data collection programs like CDC's surveillance data, these are not available across all states and may not collect data points necessary to inform coverage. So super important to really get a holistic view.
You highlight an important one, the full spectrum of the sickle cell community, because one data point does not represent the full community. So thanks for that. I want to come back to Paris and Jasmine. As sickle cell warriors, I'd like to hear from you about the importance of centering data collection on what matters to patients and caregivers. You know, payer organizations, and you hit on this a bit, Paris, aim to provide coverage that's respectful and responsive to the individual patient perspectives and needs and values. However, in order to do that, it's important that there is available data assets to help inform these decisions. So we'll start with Paris. Could you share what data you feel is critical from a patient perspective to capture those needs, health outcomes, and disparities experienced by individuals living with sickle cell disease?
Yes, like I said earlier, it's important to get a holistic vision, not just pain levels, crisis frequency, and hospitalizations, but the data that differentiates one person from the next, data that's equitable and diverse. So I would say gathering data surrounding socioeconomic status, like living situations, social activities, quality of life, visions for their future, things, you know, simple as family planning, accessibility, transportation. This information is so important and thoughtful. Thinking of ways to collect data that capture all of these things means asking questions in a thoughtful way. Are we affordable, able to afford medications? Are we experiencing food insecurity? Do we have access to mental health services that specializes in pain management? Something, you know, these are things that are tailored to our experiences. And if so, how can we provide resources and how can we help manage the outcome of the issue? Another thing I want to flag is that it's also important to gauge the patient's real world experience with hospitals and clinical centers, because that experience affects their willingness to share information and also flags any healthcare disparities a patient may face. So yeah, I'll just leave it at that.
Absolutely. And I really want to piggyback off one you said, their goals and visions for their future. Oftentimes, and we heard from earlier discussions, that failure or at least trying hydroxyurea is a prerequisite for other, but we know what the challenges with hydroxyurea, especially for individuals who want a family, may prove challenging, and that may be one of the reasons why they're not taking hydroxyurea. So understanding what are those decisions that result in how they approach their care is important. So that same question, Jasmine, what outcomes are considered to be the most important for you in terms of what data should be being captured for the sickle cell community?
I always do that, forget that I'm on pause, on mute. But I agree with everything that Paris said. And I think also I would want them to include people that I'm sorry.
No worries.
I also want that to be included with people that have moved to certain states that wasn't born there, so they wouldn't have that data to collect since they weren't there at birth. And then also family planning, transportation is a big one. I know in my small town, we don't have a lot of buses or things like that. So it's really hard having VOCs, a lot of VOCs, and experiencing depression, anxiety, and things like that, and working. And people that are working, how are they dealing with it when they're sick or whatever, or and then access to specialists. I know for me in my small town, I have a hematologist specialist, but that's the only specialist in my town within an hour and a half drive. So it's really hard if your doctor is like, I've done everything I can to do for you, so I'm going to transfer you to somewhere else. And you're hoping that it's in the same state, because if it's not in the same state and you have Medicaid or if you have Medicaid, which most of us tend to have Medicaid and Medicare, it won't be covered. And so you
Access barrier.
yeah, and then have to figure out how you're going to pay that and all that whenever, your hometown and stuff is not, you can't do it there or within your state.
So we know that geography plays a lot into social determinants of health, which is going to be the next topic of discussion. So thanks for teeing that up. We know that across the healthcare spectrum that there's been a shift to increase recognition and efforts around the social determinants of health. So Lewis and Joe Michael, you both have different perspectives from the public insurer standpoint in your state to private health plans. However, both of your organizations have a responsibility for improving the health of the members in which you serve by financing the care they need. Can each of you discuss how public and private payers can, and in some cases already do, play a central role in identifying and addressing the social determinants of health?
Yeah, so I really appreciate Paris and Jasmine talking a little bit about their experience, because I think it highlights a lot of things that payers can do. Sometimes people think of a payer as just paying the bill, but we try to look at all aspects of the patient. As Jasmine said, transportation is huge. We provide transportation to our patients. If they are transferred out of state, we do one-offs to make sure that that is covered. So I think just instead of focusing, solely on the disease state itself and just really focusing on all those other things that go into their overall quality life are just incredibly important.
Thank you.
So part of the work that we do is identifying members who would be appropriate for care management services. And so having a core component of what a health insurer can do is understanding how population is doing in terms of ED and inpatient, quality of life, all those things, and identifying disparities, and kind of trying to break down the barriers that exist for those disparities. If it's related to transportation, what can be done around transportation? But that's really the crux of population health is identifying where there's disparities and why there's disparities, and then what can be done to try to improve that. And I think for everybody that's involved at the higher level, just looking at the data and not so much for the, it's important to have the real world view from what Paris and Jasmine are able to provide, just to see like how impactful something can be. If there's it seems like a small barrier like transportation, but it can be a very significant barrier for somebody that's in a rural area or has difficulty accessing a doctor.
And Jasmine, coming back to you with your experience as a social worker, can you talk about the diverse needs of patients that you've interacted with or served, and how you work to identify either individuals or groups who would benefit from receiving specific types of services?
For me, I started out with just building a rapport with them, getting to know them as a person, wanting to know like how are you feeling, how's things going with your doctor, and all that type of stuff. And I also take into consideration their cultural differences. You never know what that may entail, and sometimes it does go to where you might not necessarily want it to have their answer to it. Whether, for example, blood transfusions. Some people don't get it for religious reasons. So, your doctor may really want you to have a blood transfusion, but with that religion, you just really can't. And so it's our way of we have to find a way to get through to them and try to understand where they're coming from, so that we can understand and better care for them. Also, I also use I think I said this, the biopsychosocial form, just because that helps a lot. And also the economic and stability and education and social communities and all that type of stuff. Trying to respect them, but also trying to get them to understand we're here for you. But yeah, we want to meet somewhere in the middle ground and not just telling them that we're gonna just do this and not consider your feelings.
A shared decision.
Yeah.
Yeah, great, thank you. In Paris, do you feel patients are open to sharing social issues that they face with their provider or insurance companies? And how can we help the community feel more comfortable discussing some of the social factors with those stakeholders, such as is it important for them to understand why specific types of data is being collected, and how it can be used in the future to support patients?
Absolutely. The why is so important. And I will say, like, just to the first question, if patients are open to sharing social issues, it's dependent upon the environment and upon the why. In my experience, I felt more inclined to share social issues in non-clinical settings because the goals of the conversations are centered around sharing for a cause, or whether it's release or to help toward a goal. I found that I'm most comfortable with sharing my experience with people in my care center's sickle cell group. So with peers or individuals who understand my personal experience and who have expressed care about the issues I face, and who have a clear path of like this, by you sharing this information, this is the outcome. And it's not just I don't even know you and you just want this information from me. So building relationships, investing time and resources, having a goal for mutual understanding is needed for the sickle cell community to feel more comfortable. And I find that to be more common in community-based organizations. This is where disparities come to light. This is where we're able to see the whole person and not just the symptoms of their disease. And this is where social support comes into play. So it would be helpful to explain to the sickle cell community why discussing social factors is important and share what the outcome of these discussions will be.
Thank you for that. I'm going to switch over to around coverage decisions and how data can really influence that. With access to significant data and the ability to change payment structures and other incentives, payers are truly at a pivotal position to make and encourage healthcare decisions based on social determinants of health data. But to do this, they have to overcome a number of barriers. So Joe Michael, in your current state government role within Virginia, can you discuss any of the barriers that you've experienced in making informed decisions to optimize care for individuals with sickle cell disease?
Yeah, so I think one of the biggest barriers that we experience is just the red tape around data sharing. So, we have one set of data in our state Medicaid agency. Our Department of Health has other sets of data and data sets. And you would think since we're all state agencies, we would be able to share them, but that's not the case. And sometimes when there are comorbidities like substance use disorder that are protected by CFR, that data collection becomes a very complicated process. It's actually something we're really focusing on in Virginia, is trying to get like a universal data sharing agreement, at least between the state agencies. And then once we can get that down, maybe extending it to some of the hospital systems as well. But, we love data. We love making decisions based on data, and the more data we have, the better. So if we could get that part down, I think we would see leaps and bounds in progress.
That's a great one highlighted. I've had some conversations with the folks leading the CDC data collection efforts, and that data use agreement, data sharing agreement, I think it's one of the biggest barriers to the broader use of and sharing of data across sickle cell. So similar question to you, Louis. What are the limits or data sharing challenges that you've experienced and enabled data-driven health equity strategy, and how have you worked to address these?
I 100% agree with what Joe Michael said, but apart from that, there's also proliferation of data. There's so much more SDOH data than there was before. And if you have too much data, it can be as bad as having no data at all. So I think there's a kind of census-based data, there's patient-reported data, there's provider-reported data, and then the number of questions and the way the questions are asked, it exponentiates. So to avoid getting to the point where you just have too much that you can't take an action or have a coherent strategy, a lot of the biggest challenge is just like, how do you consolidate that data down and synthesize it into core areas? So a lot of the work that we do is like, how do we think about what are the 3 buckets that you can get to that'll help inform where you need to put resources and how you use those resources. So from where I said, a lot of that is just what's going to impact a patient from seeing a provider, and it boils down to economics, transportation, or accessibility, and then not understanding your provider once you're there. So remember provider communication. So try to boil it down to those 3 data points and not have like the hundreds of different individual questions that you might have, and kind of leave that part for the interpersonal communication or like the actual discussions that are going to happen inside the office.
I just want to challenge you on that last one around the understanding of the provider. I think it's also the converse to that a provider is not necessarily as knowledgeable and understanding of sickle cell disease and don't really understand the needs of the community when they come to them for care, especially in areas like what Jasmine highlighted, rural areas that don't really have a lot of expertise in sickle cell disease.
Yeah, 100%, I agree with that.
So in our last discussion topic, I want to talk about collaboration, because based on what I'm hearing, there seems to be a lot of opportunities to advance our shared goals and needs and wants for leveraging social determinants of health data for healthcare decision-making. During the summit today, we've brought together a number of different diverse stakeholders to talk about the opportunity for collaboration. So if each of you could describe where you see an opportunity to collaborate for data collection and what that might look like in the last several minutes before we open up to questions, I'd greatly appreciate it.
I guess I'll go. I would say getting with different community-based organizations in your town. For me, I know every year in September, sorority, they have a sickle cell walk every year. And that brings out multiple people and then they also bring out the blood donation. So a bus so that they can donate blood there too, if they would like to. And I also feel like different advocacy organizations could help there too, because, and a lot of support groups too, because I think where we're missing with this is that we're not coming together to defeat this. We're trying to do it separately. And a lot of times doing it separately, you don't get as much of a push as you would want to, like it being very, maybe a lot of people coming and things like that. So I just think with different collaborations coming up, like it could be really an opener to some people, because they may not have ever heard of sickle cell, but may have heard of the organization that they're trying to get in. And this might be a good way to get into their good graces by coming to this or something.
Great. Anyone else? One thing I would want to flag is patient-reported outcomes, because I think oftentimes it's driven by things that aren't patient-centered, and
Yeah.
I think that's truly important.
Yeah, I was going to mention, you can look at your data all day long and speculate, what it means, but if you're not actually talking to the patient and asking them what they need, you're making decisions and assuming that they need something that maybe that's not important to them, and the data might not show you what is the most important thing for them. So I think just taking the time to get out into the community, like Jasmine said, work with community advocacy groups, connect with those people and talk to them and say, hey, what is it that you actually need? What would improve your quality of life?
So we're going to be wrapping up shortly. I just want to remind our audience that this session is about to end in about 10 minutes. So if you could enter any questions that you may have into the chat feature. Let's see, are there any questions coming in yet? Not yet. But I do have one that was proposed as a tee-up conversation. When implementing new data collection requirements or standards, payers may need to be sensitive to cultural or community level differences that necessitate flexibility. For instance, and the exact screening instrument used or even the language used to talk about a particular type of social determinant. How can payers ensure that they're collecting the right data in a culturally sensitive way?
I think that kind of what we've spoken about previously, but where the data and how the data is collected is as important as the questions that are asked. So I think that there should be more of a push where there's a closer relationship between the insurers to have PBOs be the primary area, or patient or provider offices where that data is collected, and make sure that it's a feedback loop where you get feedback from groups to make sure that they're comfortable with the questions and how they're framed, and not just kind of have it be something you throw over the wall as a requirement to be collected.
I think another one too might be testing this out with actual patients before just asking that question.
Some
and
focus
potentially,
groups.
yeah, focus groups, and also working with community leaders to potentially be contractors on how this is disseminated and the language that's used. Let's see, any questions coming in? So one came in related to community-based organizations can be important collaborators. However, oftentimes they do not have dedicated funding streams. How can establishing productive partnerships for data collection help address some of these challenges? I've seen some grants by some organizations that kind of include community-based organizations in sickle cell disease for data collection, but how have you experienced this within your own organizations or states, or in your experience living as warriors? Is there a willingness by any of your states or your organizations to include partnerships with some of these organizations and provide them funding to assist in partnering on data collection?
In Virginia, we, with our managed care organizations, we're always encouraging them to be innovative. So a lot of times if, for instance, we might say, hey, there's this clinic or there's this community organization, they're looking for a partner, and we'll try to pair them up with these organizations, these managed care organizations that just, at the end of the day, they just have more resources. more financial, more workforce. They just have more than what we can provide. So trying to kind of put the right people in the right rooms together to make some of that funding happen, and also provide the resource for their data analytics and things of that nature.
We have another question. Joe Michael, you mentioned that your organization provides transportation. Can you explain how that's facilitated, and do they contract with a local CBO to offer that to the beneficiaries?
Yeah, so we do have a transportation division in-house at our agency, but it is part of our managed care contracts. So each managed care organization has a contractor that they use for that. And just to mention, I know sometimes when you hear about transportation and insurers, it's only for appointments, medical appointments, and things of that nature. But we actually have some organizations that also provide, even if you need a ride to work, they'll work with you on things like that, because we've really recognized the importance of that transportation piece.
Great. And this one's to Lewis. There was a question, are there standard survey tools that you would recommend as a starting point to collect the most important data points?
So it depends a little bit what your area of focus is, but there's the Healthy People 2030 website, which is the CDC. I'd recommend that as a starting point, just so that has like a good construct for how to think about an SDOH like holistically. So I'd recommend that as a starting point. Then if you Google, there's actually questions you can ask for population health assessments and things like that. That are quite comprehensive. So there's a ton of information out there.
This next question makes me smile because sometimes I keep seeing these things that I think are real pictures, and it's really AI. This is the AI-driven question. With AI becoming such a big part of our world today, in various industries and research, what are your hopes for AI being used to assist sickle cell patients and providers, and what is its role in potential data collection?
Just say one thing about, so if you're looking at machine learning or AI, if you're looking at historical patterns that are undesirable, the patterns that will be detected are the ones that are undesirable. So you especially from the health equity point of view, or if you're trying to eliminate disparities, you have to be really careful about using historical data if you don't want to perpetuate what you've seen in the past. So I think that there needs to be a lot of constraints, a lot of real understanding about what you're asking AI to do. But I do think that there's a ton of opportunity for it to help share information, help disseminate information, help monitor, and kind of provide more actionable data. But it just needs a lot more, I think, guardrails on it than what people appreciate.
So as our final remarks, I want to invite each of you to share your last perspective. I imagine our audience will go back and think about a lot that was shared today, but what is one final call to action that you would like them to think about as an important takeaway from our discussion today, or something that they can do to start improving the quality of data collection efforts in sickle cell disease? So I will start with Paris.
All right. So the most important takeaway from this discussion is that accurate and standardized data collection methods are needed across the board to holistically capture the experiences of the sickle cell community. Living with sickle cell is just not a one-size-fits-all experience, and there's so much data to be found that can increase the quality of life, access levels, and financial health of our community. And this should be considered when payers are seeking to understand the community they serve. Also, collaborate with community-based organizations and patient advocacy groups. This is where you receive like a whole picture of the wide spectrum that is living with a rare disorder. So,
Jasmine?
Yeah, she sort of got what I was going to say a little bit, but I agree with Paris and everything. I think really having a community-based organization and things like that would really help out for that.
I imagine the role of the social worker is important to you as well in data.
Yes, and a lot of people don't understand how they really can help. And I know for me, I actually don't have a social worker in my whole town, and I haven't had a social worker since I was younger, and it really makes a difference in your team and everything. And if I could put a dream team, a social worker and a mental health counselor to deal with anxiety and depression and the things that goes along with this. Yeah, that's it.
Lewis?
Two quick things I'd say is my dream would be there's collaboration, so everybody is doing their own area of value add and there's and then be an appreciation for what Jasmine just described, where there's the it's really important, and this isn't an area where AI would be able to replace it.
Last but not least, Joe Michael.
And you're giving me the final word. Okay. I guess what I would envision to be best case scenario, what I would charge other people that are maybe in a similar position to myself in a payer role. Don't create an idea and then go rummaging through your data for something to support it. Start with your data and then create your ideas from there. I oftentimes see the reverse occurring because we think we know what's best in a situation, and then we look for data to support that. So I just encourage everyone, just start with your data and go from there.
The numbers matter, right?
Yep.
So we heard today about the importance of accurate and high quality data to capture the needs, health outcomes, and disparities experienced by individuals with sickle cell disease across the spectrum, because it's not a one size fits all, as Paris said. I want to thank each of the panelists for being here with us today and sharing their unique perspectives. I believe we will now take a 5-minute stretch break before the final session of the summit. Thank you so much for your time today. Turn it back over to Maggie.
Thank you so much to all of our panelists. As Tasha had described, we will be taking a 5-minute break, so we ask for you to come back to your computers at 55 for our last and final session of the summit. Well, I know that break felt a little short, but I'm happy that we can move through the last session and then close out today's day. Next slide, please. So our next session and the final session for today is titled Measuring Value for Cell and Gene Therapies in Sickle Cell Disease. Today, I'm honored to introduce our 4 panelists that will be participating in providing presentations followed by a moderated group discussion. Our first panelist is Clay Alspech, who is the principal at Levitt Partners, specializing in federal healthcare policy and advocacy. At Levitt Partners, Clay helps lead the federal insight and advocacy practice areas, as well as a number of alliances, including the Sickle Cell Disease Partnership. Additionally, we have Dr. George Gosha, who is an assistant professor of medicine at Yale School of Medicine. He's a hematologist and internalist with medical methodology training in risk and decision science. George has founded the Research Hub and the first quantitative decision science laboratory to address clinical and health policy challenges in hematology and oncology based in Yale. His multi-institutional collaboration has been the first to report on the quantitation of health equity in sickle cell disease, and we're excited to welcome him into the conversation today. Our next panelist is Catherine Kula, who is ICER's Director of Patient Engagement. In this role, she builds on strategies to strengthen the patient voice within ICER's value assessment. Her direction of ICER's patient engagement program includes outreach and onboarding for ICER reviews, contributions to patient perspectives and ICER's policy papers, enhancing ICER's resources to be more patient-friendly, and nurturing relationships across the patient community partners. And then last but not least, we have Derek Robertson, who is the president and co-founder of Maryland Sickle Cell Disease Association. Derek and his wife Shante have 3 sons, 2 of whom have sickle cell disease. Derek is an attorney specializing in federal 340B drug pricing discount programs with expertise in establishing hemophilia treatment centers in the program. He's a member of the NACIM Forum on Regenerative Medicine and has been a member of NIH's NHLBI's Sickle Cell Disease Advisory Committee, has served on HHS's Advisory Committee on Inheritable Disorders, and federal newborn screening expert panels. We're looking forward to inviting these 4 panelists to bring their expertise to this topic today. Next slide. Our session goals are to discuss patient-centered methods for evaluating clinical and cost effectiveness of the emerging cell and gene therapies for sickle cell. Additionally, our discussion will highlight opportunities to use innovative payment models for these emerging therapies. The presentations brought together by these panelists will also identify approaches to promote equity in economic evaluations and future coverage policies for these therapies. Next slide. So today we'll be hearing 4 different presentations. Derek will lead talking about measuring value from the community perspective. And then we'll hear from Dr. Gosha, who will describe decision science and clinical medicine and his the difference between conventional and distributional cost effectiveness analyses for sickle cell disease. Next, we'll hear from Kat, who will provide updates from the 2023 ICER review of 2 gene therapies in sickle cell. And then finally, we will have Clay provide updates from the Sickle Cell Disease Partnership and talk about policy advancements. Finally, we will hold all of our questions to the end, in which we have a Q&A and moderated discussion. Next slide, please. Some things to note is that since we are talking about some of the economic specific models that are used in this population, there are some specific terms and definitions and abbreviations that will be used throughout these presentations. We'll go ahead and drop these into the chat so that you all can use them as a resource and refer to them throughout the presentation. Next slide. And so with that, I would love to invite Derek to come up and kick off our presentations.
Thank you, Maggie, and thank you to the fellow panelists, and thank you for everybody for attendance. It's been a great discussion so far. And I think I'm just going to approach this topic more from a kind of qualitative perspective. And then I think later in the discussion, we'll hear more quantitative analysis from Iser and Dr. Gosher and others. So let's just get started. Next slide, please. So we're talking about value, and I think it always starts with definition. So, how do we define value? What price are we talking about? And are we asking the right questions when we're looking at determining value? Next slide, please. So value can be defined in a number of different ways. And so I pulled this from an online source. And if you look, the first three really talk about quantitative issues. How much money does something cost? What's the value of a car? It's $10,000, or what's the value? So you're looking at it in terms of money. The last bullet, I think, is also equally important because you're looking at utility, and you're looking at something's worth and how do you value that? And that's something I think needs to be taken into consideration when we're looking at high cost therapies as we move forward. And so you're looking at the importance in comparison with something else, and what that something else is also important. And, we can talk a little bit about that as well. Next slide, please. So there are currently expensive therapies out there. So this is not our first go around as a society in looking at expensive therapies. And I think it's important to put that into context. It's the first time in sickle cell disease that we are really looking at therapies in general. And some of these therapies are what we would consider expensive. But the healthcare system has long paid for expensive therapies. And I use the example of hemophilia. I've worked in hemophilia for the last 30 years. And I think it's very interesting to see how payment models came up about that. So a very conservative estimate of the annual costs that's paid in hemophilia could be about $2 million. And there are about 30,000 patients with hemophilia. Many of them use much more than 5,000 units per month, but some use fewer. And I just rounded up $1 per unit. Most clotting factors cost more than $1 per unit. All of these drugs are paid for by all the major payers. So Medicare, Medicaid, private, and then you have manufacturers who are providing co-pay assistance, so there's rarely an instance where somebody with hemophilia trying to get clotting factor can't get it paid. And it's dispensed through specialty pharmacy. These are at-home infusions, generally self-administered. And I think one of the earlier panelists, there's a question about a medical benefit versus a pharmacy benefit. And in hemophilia, even though these therapies are infused at home, there's a mix between whether they're on the medical side or the pharmacy side, and that a lot has to do sometimes with payer decisions and also patient advocacy. So we can go to the next slide, please. So these are some of the expensive therapies that I was mentioning. So you have certain curative therapies, just like sickle cell disease. 2 new gene therapies came out for hemophilia. One of them is about $3 million. So they have the most expensive drugs currently. And there are various payment arrangements which are being looked at. We'd have these value-based arrangements. There are warranty programs, and we'll talk a little bit about that as well. Next slide, please. So why should we pay for expensive therapies? And I lifted this and give credit to Cynthia Paig, who is a consultant with Aon. And she looked at it from what she called the 4 E's. And I really like that. So you start with, does the therapy work? If it doesn't work, then you're not going to get it paid for. What's the economics of it? And you're going to hear some of that from Iser and others. But there are other 2 E's. What about the emotions involved? What is coming from the patient advocacy, community advocacy, and the ethics of it. Is paying for it just simply the right thing to do, right? And so those are some of the things that give to why you should be paying for expensive therapies. Next slide, please. So will payers pay for sickle cell disease curative therapies? And I use the word curative loosely. I heard from Dr. Shah's presentation that some of these gene therapies are not necessarily quote unquote curative, but we can talk about that separately. Certainly, we have stem cell transplant, which is curative, and it's about $300,000, and some payers will pay for it, including federal and state payers, but this is not universal. Next slide, please. So for gene therapy / gene editing, which are two, that are in front of the FDA now, we don't really know the cost. I mean, it could be ICER's estimate, or it could be others, 2.5 million. What we do know is that there are other expensive gene therapies out there. Luxturna for blindness, Zolgensma for SMA, and these are, you can see the prices there, and payers are covering these at those rates. Next slide, please. So we need to make sure we are covering those 4 E's in sickle cell disease, right? So clearly the therapy has to work, and we're going to need long-term results that come from that. The last session that was just moderated talked about the value of data, right? That's some of the economics, because some of it has to look at how can we value this cost, and we need to be able to see how we can get the data around the value of this product. In hemophilia, when they came up with gene therapy, I mentioned in an earlier slide that there's about $2 billion of expenses or more on current therapies in hemophilia. So it's a little bit easier on the hemophilia side because the payers or the patients or the advocates, they can look at one therapy and say, okay, we're paying this now, and compare it to the cost of what we would pay. We don't have that in sickle cell disease. And so we don't have that nice, neat comparator to say, okay, let's look at XYZ, and we just simply don't have it. So we need to be looking at issues like burden of illness and how should that be included in the equation. And certainly patient advocacy. We have to really make sure that and get that advocacy piece down, because we could look at this from the perspective that if it's not covered and this is a therapy that does work, we're creating yet another disparity in sickle cell disease. And again, if the therapy works, is it unethical that we're not having access? Next slide, please. So how will it be paid? And I know others will talk about these payment mechanisms, but we can look at what currently exists for some of these gene therapies, and we can see that you have various value-based payments, you have subscription policies, so the payers are coming up, the dynamic is changing as to finding ways to get this paid, and we can talk about this more in the Q&A. Next slide, please. And we can go through the next slide, please. And so I think the key takeaways here, I think, is that currently the healthcare system is paying for expensive therapies, and payers are still generating profits, right? Here's some of the 3 larger payers. These were the 2022 profits. So let's go to the next slide. And I think one of the things we want to do is to make sure that we understand that these therapies can be paid for. That we don't want a situation that when it comes to sickle cell disease, we're saying, can we afford it? And I think we really need to reframe the question and stop asking, how can we pay for sickle cell disease cures? And really start asking the question, how can we afford not to pay for these cures? And I think I'll stop there. I think that is the last slide, and pass it to the next presenter. Thank you.
Thank you so much, Derek. And we're all set. Dr. Gosha, if you want to move into your presentation, thank you.
Beautiful. Thank you very much. Thank you for having me here today. I get to have the privilege of both being a hematologist and decision scientist. And so to see both worlds. Today, I'm going to focus on the health economic aspects of the decision science perspective. I have no conflict of interest, and let's move forward. Next slide, please. Beautiful. What I want to present to you is work that was initially presented in December at the American Society of Hematology and then published in May in the Annals of Internal Medicine this May. And it specifically is a distributional cost effectiveness analysis of gene therapy versus the standard of care in sickle cell disease. I want to acknowledge my co-authors in another multi-institutional collaboration across both Yale, our Sickle Cell Comprehensive Disease Center, as well as the Department of Health Policy Management at the Harvard School of Public Health. The individuals are listed here before you. And may I request the next slide, please? Beautiful, thank you. So gene therapy pricing by indication, we know that gene therapies are expensive therapies. Ideally, they're going to be one-time therapies. From spinal muscular atrophy all the way to hemophilia B, we do have price tags for those therapies. Hopefully, when we hear more information in December about the eventual FDA approval, soon after we will find out pricing as well for gene therapy products for our patient population with sickle cell disease. Now, Kat, who's going after me, is going to talk about the conventional cost-effectiveness analysis and present ICER's findings. Here, I will focus on the distributional cost-effectiveness analysis, which is a way to account, one way, I should say, to account quantitatively for health equity considerations. Next slide, please. You don't need to memorize a formula in front of you. The only reason I have it here is so you can see the components that go into it. The concept here is something called an equally distributed equivalent. You do not need to remember that name. But what goes into it is the population size, the health in each group, and something, and this is the key component, the inequality aversion index. The other term for that we can use colloquially is an equity weight. So this is an Atkinson-based formulation of the EDE, formulated more than 50 years ago now, originally derived from health income inequality. And so we know for the US general population, generally speaking, that the inequality aversion index, again, derived from work done in income inequality, pegs the rough threshold estimate of this epsilon, which is the inequality aversion index, anywhere from 0.5 to 3.0. And so what we set out to do is we set out to actually use a prior analysis with its conventional findings, which actually end up, looks like mirroring ICER's findings on the conventional side of things. And we take that and we build in the health equity component to show essentially what the effect quantitatively can be of health equity, essentially in a way showing that the blue sky is blue. And so next slide, please. And so I'm giving away the final result, and I'm going to build back to it. But in our distributional cost effectiveness approach, the threshold epsilon, i.e. the inequality aversion weight, or otherwise known as the equity weight, is 0.9. If you remember the range that has been accepted by the US general population in the past is 0.5 to 3. So the world of 0, for example, for the equity weight, is the world of conventional cost effectiveness analysis, where we don't care about equity. And then as you move up with positive numbers upwards, we start to care more and more about equity. And so the question is, what is the minimum threshold here for specifically the decision of gene therapy versus the standard of care? And so on the y-axis here, this is a visual schematic. At the top, there's an exacerbation of disparities. This is very loose and broad. And the bottom, there's reduced disparities. And on the x-axis, something called net health benefits. And here you see essentially the two worlds, the world of standard of care and the world of gene therapy. Here we price it at 2.45 million, kind of smack down, right in the middle between spinal muscular atrophy and then thalassemia. This was before we did our analysis about 1.5 years now ago. And so this is before the hemophilia B pricing was out there. And so we kind of picked that middle line here. And so can I request the next slide, please? Beautiful. And so how should we interpret a threshold epsilon? This is akin to asking, an analogous question that I highlight a phenomenal PhD student at the Harvard School of Public Health for this slide. So the analogy is, who would accept a more equitable but less cost-effective option? And so can I get a next click, not a next slide, because there's something that's going to show up on the bottom of this slide here. Beautiful, thank you. And so the analogy here is who would pay for a more effective but costlier option. And you see the individual country flags, the willingness to pay thresholds, generally speaking. Again, there's no consensus willingness to pay that's accepted in the United States, although we have a pretty good confidence interval for where it is, and a really nice paper for what that point estimate is, just published a couple years ago in the Annals of Internal Medicine. And so this is one nice analogy to be able to think about this concept. So with that, can I request the next slide, please? Beautiful. And so our objective in our analysis was to take a prior analysis, restructure it, apply it to patients who are clinical trial eligible at the age of 12, and show the results both conventionally and then distributionally. We did it over a lifetime with a Markov model. And the perspective here, importantly, is the US health system perspective. And the outcomes are the standard outcomes that we would expect, but including an equity weight on top. So next slide, please. On the left, you see something called a state transition diagram, and you have patients who are transitioning from mild to moderate to severe sickle cell disease. And then on the right, you have gene therapy, and patients are in lifelong disease remission. On the very far right, you see actually the Markov tracing of these different patient populations. So specifically, are individuals with mild, moderate, or severe disease defined by vaso-occlusive crisis requiring hospitalization in the original study. And so in the middle, you see our recapitulation of that conventional analysis, basically verifying first that we have captured accurately that patient population. And so now with that, next slide, please. Beautiful, thank you. And within this, you'll see both the standard of care, the gene therapy. The first row is cost, then you have quality adjusted life years, and then the incremental cost effectiveness ratio coming in at $176,000. This is US health system perspective. With ICER's analysis, I believe the same perspective came in right around $193,000. Their input parameters were a little bit different. I think they used a price tag of $2.0 million for gene therapy, and Kat will correct me if I'm wrong. But the important component here actually is at the very bottom. So what is the equity weight? The threshold inequality aversion parameter for the base case. So for our patients with sickle cell disease receiving gene therapy is actually 0.9, right in the range of what's been accepted previously for the US general population. And so with that, next slide, please. This is a nice heat map type of way to capture the same thing. And so on the x-axis, you see the inequality aversion parameter starting at 0. Again, this is the world of conventional cost effectiveness analysis, which you'll hear from Kat, and all the way through on the x-axis to the top, we go out all the way to 10. But in the box, you actually see 0.5 to 3. On the y-axis, you see the gene therapy cost. And this way, we can actually get an idea for what a fair, equitable price for gene therapy is. In addition to just a pure conventional price as well. And so with that, may I request the next slide, please? Thank you. And these are scenario analyses. And so we are focused on and talking about the durability of gene therapy, and we wanted to show our readers and stakeholders the circumstances about which they're wondering about. So what if gene therapy is durable for only 20 years? What is the ICER then, right? What if gene therapy is durable for only 10 years, right? So the less durability we're going to have for gene therapy, right, the higher the incremental cost effectiveness ratio is going to be. Our question, however, is what is the threshold inequality aversion parameter have to be? Is it still going to be in that previously accepted for 50 plus years range? And you can see in the very last column, it is all across the board. It continues to be 3 or less. The last scenario that we've presented in this paper is in the background. We actually looked at comorbidities, right? And so we took a look and conversing with our bone marrow and transplantation colleagues who are co-authors on this paper, just getting an idea for what may be comorbidities that will exclude individuals from receiving or being eligible for gene therapy. And here we ended up selecting heart failure or pulmonary hypertension, and knowing their incidence rates in our patient population on a national level, we're able to construct a model separately that shows that maybe about, upwards of 20% of individuals may have one of heart failure or pulmonary hypertension by the age of 12, that eligible age in the clinical trial setting. And so in that context, then in that world, what would the threshold inequality aversion parameter have to be? And you can see that here it's 0.8, so the lowest value out of any of the values. And with that, next slide, please. And this is the final slide. And so budgetary constraints, have driven therapy availability and the lack thereof for patients. So we're going to discuss in the Q&A, of course, in the discussion portion, kind of the practical implications. But the take-home message for us is we believe that the quantitative capture of health equity and being able to derive an equity weight threshold just provides an additional transparent metric for these difficult decisions and important conversations that need to be had. Thank you very much. Next slide. And thank you to all my mentees and all my collaborators. Thank you.
Thank you so much. And now I'll invite Kat to come share on ICER's updates.
Wonderful. Thank you, Maggie. Hello, everyone. Happy to be here and great panel sessions throughout the day, and excited to kind of build on what others have already shared. So again, I'm the Director of Patient Engagement here at ICER. You can go to the next slide, please. And I wanted to, with the few minutes that we have together, introduce ICER, share the key findings from ICER's 2023 Sickle Cell Disease Review, and then share some of our coverage, pricing, and payment policy recommendations that came out of our public meeting. Next slide. So for those who might not know of ICER, we are a completely independent nonprofit organization. We're primarily a research institute, and the type of research that we do is called Health Technology Assessment, or HTA. HTA is basically a process that allows you to compare one health intervention to another health intervention, typically a new health intervention to an existing intervention, in order to measure the added value that that intervention brings to society. And so HTA not only looks at the clinical and economic value, but also it cares about the social and ethical aspects of value that a new intervention brings. Next slide, please. So in terms of the goals of HTA, it is usually twofold. One, the comparative clinical effectiveness analysis helps us inform decisions that look at how safe are new interventions and how effective are they, and gives us the ability to balance the benefits and the risks of a new intervention. In addition, our comparative cost effectiveness analysis allows us to ensure that the price of interventions matches the benefits that patients actually receive. So at ICER, we hope to help inform decisions around drug pricing and patient access in the United States by looking at the added value of new interventions, especially the ones that are coming in through the FDA's pipeline. Next slide. And so finally, before I go into the sickle cell disease report, I wanted to also share, in terms of ICER's role in the US health system, we are primarily an evidence review organization. And so everything that we're able to incorporate into our assessment, it really relies on the data that are available. Generally, it's clinical trial data and sometimes other published literature that we have. And unique to the US healthcare system, we know that as soon as a new drug is approved by the FDA, the maker of that drug is choosing a price, and insurance plans are all trying to figure out how to cover that drug. And so we believe that it's important to publish our research report around the same time that the FDA is making their decision on approval, so that we can produce this independent body of evidence to help inform decisions around pricing and access. And finally, ICER, we inform, we don't decide, so we have no authority to make decisions about drug approval, pricing, or coverage, but we hope that our research process or public meeting and our report can offer recommendations to decision makers that are thinking about price and coverage and fair access for all patients. Next slide. Thank you. So as a very high level overview of sickle cell, of our sickle cell disease review, we previously reviewed therapies in 2019. And this year we looked at 2 of the gene therapies, lovo-cel and exa-cel. So the goal of this review was to, 1, figure out how well did these therapies work for patients, and 2, to recommend a fair price range for these therapies based on how well they work for patients. So I will say that my overview right now will be very high level. I direct everyone to the full ICER report that has kind of all the details and results from the report. Next slide, please. So when we think about how well do the gene therapies work, the majority of our data came from clinical trial data, and we found that for both lovo-cel and exa-cel, these therapies were really significant in their ability to reduce painful crises, to reduce the number of hospitalizations, and then to overall increase the total levels of hemoglobin. And so this is certainly not all of the outcomes that were captured, but these represent some of the very significant ones, especially for patients. And I also want to flag that these only show kind of short-term benefits given the follow-up data that we have. Next slide, please. So now that we have an understanding of how well these therapies are working, we want to then consider what is a fair price range for both of these gene therapies. And so at ICER, we like to think about a fair price being the price at which a treatment should cost based on how well it works for patients. And if you'll please click, we found that through our economic analysis that the fair price range for both lovo-cel and exa-cel is between $1.35 and $2.05 million. And this price is for a one-time treatment. And so this is a very high price for a drug. And we also believe that it's a very fair price for these therapies, given how well we found that the gene therapies were working for patients. So this is very exciting for us to be able to share. Next slide, please. So working backwards a little bit, I wanted to kind of show how we went about calculating this fair price range. And so we had a number of different inputs that went into our economic model. So if you'll please click, it'll populate some of the factors that were included, such as patient age, the number of pain crises experienced, the benefits and risks of treatment, complications related to sickle cell disease, patient-reported level of health, medical costs, as well as productivity and unpaid work costs. And so all of this went into our consideration of what a fair price should be for both of these therapies. Something also to note, George, you were totally correct. We did use an assumed placeholder price of $2 million for these therapies, given that we don't have a price yet. And if you click again, I wanted to highlight that, we have a patient engagement program and we engage all stakeholders throughout the ICER process. And a lot of the patient community input that we received on the draft report helped ICER revise the average number of pain crises that we had initially been informed from the clinical trial data, but we just heard from the community that was an underestimate. And so we actually increased this number from 4 to an average of 5.1 pain crises. And we're able to revise that into our model. And if you click again, I also wanted to talk a little bit about the productivity and unpaid work costs that we incorporated into this analysis, which was part of our societal perspective. Next slide, please. So when ICER finds that the indirect costs of treatment have a great impact on patients and families, we are able to elevate the societal perspective as a dual base case, in addition to the healthcare perspective, which is what we were able to do for the sickle cell disease review. And so we found in the literature data to support annual lost patient productivity at an annual number of $19,200, and then caregiver unpaid work annually at $19,600 per caregiver. And so these were applied to adults for the patient productivity and then adolescents for the caregiver in the standard of care arm. And these costs were assumed to be eliminated after successful treatment with gene therapy. And so at times when we have these data available to incorporate this into our societal perspective, we are excited to be able to do that and to have a different base case to also present. Next slide, please. And so switching gears now a little bit into what we learned from the policy roundtable and engaging with patients and clinicians and insurance and the manufacturers throughout the ICER review process. We had a number of recommendations that came through for coverage, pricing, and payment. And so I just wanted to highlight a few here that I think that previous panel sessions have already touched on. And so at ICER, we recommend that payers should design coverage policies that can support travel for patients and their families, especially given that these gene therapies will only be accessible in specific medical centers. We heard a lot from both patients and clinical experts about future fertility being a key consideration in management of their disease. And so we also recommend that payers should cover fertility preservation and along with coverage of gene therapies. Next slide, please. And I know I'm closing in on time here, so I'll just end here with some recommendations for pricing. We recommend that right now, manufacturers should price these new treatments at the lower range of cost effectiveness, so closer to that 1.35 million until we have additional real world evidence on the longer term benefits of these therapies, and that we know that pricing lower will produce fewer access challenges, both for the health systems and for patients. And so that is really important to keep in mind. And I'll close out the presentation here. I have another slide on alternative payment models that I'm happy to discuss more during our discussion. Thank you.
Thanks so much, Kat. We'll keep moving through the slides until we get to perfect, and then our next presenter will be Clay. Thank you so much for being here today.
Yeah, thank you for the opportunity to be on the panel, and thank you for the opportunity to be part of the summit. It's been a great discussion today, so just really thankful to be a part of it. And what I intend to do today, just similar to my prior panel members, some of my topics have been covered already, so I'll try to keep that short so we can move to questions. I'm Clay Alsbach from Levitt Partners. Thank you, Maggie, for the introduction earlier. We are honored to be advisors to the Sickle Cell Disease Partnership. So what I'm going to do is go through a quick overview of what the partnership is, and then get into a discussion around the CMMI model that Dr. Hughes and Ashley talked about to start off the summit earlier today, and walk through some of the recommendations we've made related to that. We're really encouraged that the model is moving forward, and glad to provide input and appreciate all the opportunities to do that. So with that, we can move to the next slide, just to give a quick background on the partnership. So our mission is to basically try to achieve specific federal policy objectives. I'll walk through those in a minute, but those were federal specific. There are a lot of efforts in the states that are very important, and localities as well. We concentrate on the federal level. And our vision, which I think is shared by probably everybody on this call right now, is that everybody living with sickle cell disease has the ability to live to his fullest potential. On the next slide, just to give an overview of who our members are. We have a great membership. Sickle is part of and has been an invaluable member since the beginning. So we're really thankful for that. But we have a really important cross-sector participation, which I think is really important to conversations around how to move the best policy forward. At Levitt Partners, we do a lot of alliance work, and what we find is the best policy comes from bringing people together to have those conversations. That's why this summit is such an important effort, and stuff like what we're doing in the partnership is important to have those conversations to enable policymakers, whether at the federal level or the private sector, to move forward in the best way possible. On our next slide, just want to give you a little bit of background of kind of where we're coming from. We are indebted to the National Academies because our work is based on their great effort that was put forward and released in September of 2020. They released a report called the Addressing Sickle Cell Disease, a Strategic Plan and Blueprint for Action that included a number of recommendations for basically what needs to happen to address the challenges and problems that we all know exist with sickle cell disease. And so our goal is basically to move the policies, the consensus-based recommendations that were developed as part of this report, to move those forward. Why the National Academies, those familiar with this great organization, they don't do advocacy. And so we are very thankful. They're observers to our effort, and we're very thankful for all the thorough the thorough recommendations and all those who contributed to them, that we're able to bring those forward. In particular, and for this panel today, on the next slide, kind of walks through basically one of those recommendations. They, in part of their report, includes addressing barriers to basically the current and pipeline access for treatments for sickle cell disease. And one of the recommendations they come forward with is basically CMS should work in collaboration with private payers and others to identify how to address the upfront costs of the gene therapies. And as part of our work, what we were endeavoring to do as part of this is to try to seek and ask CMS, CMMI to move forward with a model. And that's why on the next slide, we were so encouraged that in February, they actually did release the model. It was one of those moments where after talking about it for a significant amount of time, to see them come forward with the model was incredibly encouraging. And Dr. Hughes actually walked through and had this kind of very similar slide earlier, but one of the specific models that was announced related to basically how to move forward, working with states, how to move forward outcome-based arrangements for gene therapies. And specifically, they do, in this, they did mention sickle cell. And so what we've been doing since the release of this is trying to help the Innovation Center help CMS as they're moving this forward. And so on the next slide, I can kind of give a little more depth as to what that entails. So in terms of where they are, as Dr. Hughes mentioned earlier, they've released the kind of the parameters, the high level information on what the model is going to look like, and then have been endeavoring to talk to and speak with a number of different stakeholders to try to put that together and develop what that model is going to look like. So that includes states. I think one of the big questions that we have from the partnership is basically like which states the CMMI would work with, and are states interested in working on this. I think we've received encouraging reports from the Innovation Center that yes, there are states that are interested and want to work on this, which is great. But that's just one of those communities. In addition to that, I think what is absolutely so important to the members of our partnership, but this community, is that CMMI do outreach to the community to understand what their, where they are and what this model is, what would be success for them as part of this model. And so as we look at this, as that's moving forward, I think that's going to be one of the key parts of this, is as they're going through the different phases of a model, whether it's the development is where we are now, to when they become public, to when they're going to testing and evaluation stage, that in all parts of that, they're incorporating that perspective of patients and their caregivers. I think one thing that in my experience and being in the policy world for a while is that it's one thing to just to say that, it's another to actually put that into practice and implement it. And I think we're really hopeful that in this model that CMMI will actually incorporate that the perspective and is doing that outreach to incorporate the development stage. And then we will be able to work with them to incorporate that perspective, that really important like evaluation, ensuring that it's actually meaningful for the patients, their caregivers, in the evaluation and testing phase as well. And so that is just one of the elements that we're trying to work with them on, and would encouraging them to do that in this model. And I would just say, hopefully they'll do that in other models as well. One of the key pieces that we are talking to them about is we're really, again, use the word again, really encouraged by the gene therapy and that they're moving forward with this. But there's a significant issue with access to current therapies. Maggie walked through this earlier during her presentation, but as you look at the different step therapies, the different gating functions that are out there, patients don't have access to the therapies currently in the market. And one of the key pieces that we discussed with CMS, we discussed with CMMI, we talked to the Hill, to Congress about is we need to fix that. And as while we are hopeful and want the gene therapies and access needs to be there for those products, we also have to fix what's currently a problem with the access to the therapies as well as to care. And so that is just one key piece. I take away that hopefully you'll take away from my piece is that just to reiterate that current problem, that current issue that needs to be solved. Dr. Hughes, I'll just wrap this up. Dr. Hughes also talked about data during her presentation, and that is a huge issue in this space. And we know HHS is taking efforts to help in solving and looking at that. But until we get better data, we're not going to be able to solve the challenges. And so data and better understanding kind of where the problems lie and how we fix those is absolutely going to be a key piece to this, not only in this model, but writ large. And then just to close it out, the wraparound services and just what goes into childcare, lodging, transportation, the elements that Dr. Hughes talked about during her presentation are absolutely vital to the success of this model. It's not just about that, the access to that specific therapy. It's about, because of how intense these therapies and what it involves for a patient and the caregivers, and to solve the equity challenges that are so prevalent here, we need to ensure that as the model is being put forward, they're taking into account all of those different elements of where these patients and their caregivers are, and to enable them to access this and to solve the challenges that they're facing. And so we are hopeful that we'll be able to work through the partnership, with them as they're developing it to ensure those challenges are addressed and are incorporated and frankly are tested and as part of the success, as part of this model. And so with that, I'll close out and say thank you again for the opportunity and look forward to the panel discussion. Thank you.
Thank you so much, Clay, and thank you to all of our panelists. So now I'm going to invite all of our panelists to come back. We'll lead a moderated discussion for the remainder of the session. A reminder to our audience, please submit your questions into the Hoopa chat, and we will ask those directly to our panelists to get them answered. So I was really excited about this panel because, as you see, each of you have such an important role in this conversation. And it's really great to hear your expertise represented across the presentations. One of the goals of this panel was to identify approaches to promote equity in economic evaluations and then ultimately for coverage policies. And so I was really happy to hear both George and Kat discuss ways that while their model was different, there were supported health equity considerations in each. And so I wanted to first ask you, George, why do you feel that it is really important to have an equity-informed economic model where, if you could talk a little bit about the importance of quantitatively measuring health equity considerations into the model?
Sure thing, Maggie. Yeah, and we know that quantification ultimately informs stakeholder decisions. We've had multiple patients denied therapeutics that would have made sense for them based on quantitative grounds. And I'm not talking about just in sickle cell disease and across a number of rare diseases. So with that, we knew that quantification was going to be important to complement all of the important qualitative work that's being done in equity. And then thinking about the opportunity to, with new methodology now only maybe 10, 11 years old out of the University of York, to really utilize that for the first time in hematology and actually think about how do we build something transparent. We're kind of thinking about building an equity atlas, actually, about taking all these important clinical decisions that need to be made and layering on that quantitative component of equity. And specifically in the context of our patient population with sickle cell disease, this is a historically marginalized patient population. And we thought that it would be a wonderful way to showcase that even if conventionally speaking, some prior analysis show that maybe conventionally, gene therapy may be cost ineffective at a certain price tag with certain assumptions, that taking all of those same essentially quantities that we can show that, okay, even if that's true, this is still an equitable option.
Thank you so much. And Kat, I would love to hear a little bit more. I know you had mentioned that due to the health equity considerations that need to be in place for a population such as sickle cell disease, you discussed that ICER had used indirect costs, including loss of productivity. We also received a question from the audience indicating that sickle cell impacts not just the individual living with disease, but also the caregiver, and the caregiver could lose income when they are caring for an adult warrior, so not even just the pediatric population. Can you discuss if this was a consideration that was built into ICER's report, and then additionally, if there were any other kind of considerations that impacted the process that ICER did while using that conventional CEA method?
Sure. Thanks, Maggie, and thank you for the audience question. Maybe I'll start there. We certainly heard about the impact of caregiver costs to both adolescents and adults. I don't believe we had the data to incorporate that directly into the model, which is why the caregiver unpaid work cost that I presented on was specifically incorporated for adolescents. So I think that was just a gap in the evidence base that didn't allow us to do that, but that's certainly something that came through in our engagement with the community. In terms of other ways that we incorporated, at least thinking about health equity, that was certainly a point of discussion throughout the process as we engage patients and caregivers throughout our process. It is just difficult to quantify that necessarily into an analysis. And so we've tried our best to kind of characterize that within our patient and caregiver input chapter in the ICER report, as well as just looking at benefits beyond health. And so things that we understand that are priorities for the patient community that we can highlight and elevate within the chapter dedicated to potential other benefits of having these therapies available to the community. And so those definitely came up in discussions throughout the process, and then were very much the root of a lot of our policy recommendations that I did present on in terms of ways that we could be thinking about designing coverage policies to be more equitable.
Thank you so much. Derek, you also mentioned that one of your concerns with the emerging new therapies could be that other disparities could be created. And this idea that some individuals from the sickle cell community could potentially have improved or better access to these therapies versus others. I would also like you to kind of have an opportunity to clarify that a little bit, but also speak to what we had heard from the other presenters and throughout the day is really the need for these supports or services that patients may require in order to make gene therapy really accessible. And these are things such as transportation, lodging, meals while traveling, and they can also include childcare or potentially childcare of other kids as well. So Derek, is this something that is on the community's radar? And if so, what considerations should we be discussing with stakeholders to ensure that these services are supported?
Yeah, thank you. I think, Maggie, sorry, I think that clearly that is on the radar, and it was mentioned in the last session as well, especially around transportation. And it really, again, comes down to who pays for it, because I think we all recognize that that's a need. And we also know that many community-based organizations, not just in sickle cell, are under-resourced. And so you have to get to that question, should the payer be paying for that, or should the manufacturer be paying for it? Somebody would have to pay for that. But I think if we can recognize that there's a need, I really believe that once you recognize that there's a need, where kind of the old at maxim, right? Where there's a will, there's a way. And it starts with that. And that's what I'm saying in terms of reframing the question, right? So if you start from a premise that this has to happen, then you're better likely to get a solution, as opposed to if you question if it even needs to exist in the first place. And in terms of the inequities, clearly, I'm not a clinician, so I'm not sure exactly how these gene therapies are going to be administered. But if it's like other therapies, it's probably not likely that every single site will administer the gene therapy. You're going to have the administering sites, and then and Dr. Ghosh is, and then you're going to have the follow-up sites, right? And so I think that that's something that, again, who pays for that? Because that's really becomes the key. And we think in terms of advocacy. Organizations like SC Red and stuff are doing so much work on fertility preservation and things like that, that those are where the advocacy comes in.
And Clay, I know that you had talked about this in terms of the CMMI model and really the importance of prioritizing that. Are there other opportunities for policy recommendations for other payers as well to incorporate these supports and ensure that they are being paid for?
Yeah, it's a great question. I think that as much as like my presentation was focused on CMMI, this is a conversation that's happening, as you all know, we're having it here across the policy world. That's one of there's some legislation pending in Congress to look at outcomes-based arrangements, and a lot of it's being driven, frankly, by the sickle cell treatments that are moving their way through FDA. And I think Derek's points, I think, are right on in terms of just the payment, who can take in, who can pay for this, like what in the societal discussions around it. And I think that's what we need to do, though. We need to talk about it and as early as possible. And I know these treatments are on the verge, but there are other gene therapies that are in the pipeline as well, and we'll have similar type of challenges. And I think this is, as we look at gene therapies, these are issues of first impression, just given their nature and how they're and what they are. But it's incumbent upon us to take and have these discussions now, because there will be access challenges, right? We know that already in sickle cell. And if we don't have these conversations now, we're going to have access challenges around the gene therapies too.
And if I might add really quickly, there are payers that have foundations, and they're looking at that now. So, and that's another way how we have to learn to advocate to see where are these resources available currently.
Yeah, Derek, I think that's a great point, and something I know that the advocacy community is really keyed into this, and that we'll be continuing to get involved in these conversations as these therapies move through the pipeline. Well, unfortunately, our time is up for this panel today. So, oh yeah, go ahead.
Just
Derek.
really quickly, there was a question in the chat about physician education. I know Dr. Ghosh could probably answer this better, but just to point out, the NHLBI had their annual sickle cell conference a couple of weeks ago, and a day and a half of that was dedicated to gene therapy. And so I think that at least is going on already. So I don't know if Dr. Ghosh wanted to say anything about that really quickly.
No, I completely agree. Nothing to add.
Great. Well, to all of our panelists, thank you so much for participating in this session. And for our audience, I know that there were some additional questions that we didn't get to answer, so we will be going back and answering them. And then, as we said, these materials will also be available after to reference and refer to that hopefully can answer some of those questions as well. So with that, I would like to hand it back over to our president, Ashley Valentine, for her closing comments.
Great. Thank you, Maggie, and thank you for all the panelists today. So I really want to encourage all the attendees to take a moment after the coverage summit and think about 1 to 2 things that really resonated with you. For me, it resonated that there are many different types of stakeholders thinking about coverage and access for sickle cell disease. We heard from federal stakeholders, how they're working to make sure that the government is supportive of people living with sickle cell disease. We heard from the patient population and community-based organizations and how they're working with our private and public partners. We heard from commercial payers. We've heard from Medicaid directors. We also heard from coalitions that are working to support the sickle cell disease community. And we heard from some of the data scientists that are working to build some of these models that can inform and will inform coverage and access for sickle cell disease. And the other thing that really stuck out to me is just how important it is that the patient voice is being highlighted over and over again. So I really want to thank you all, and I want to thank the moderators and the panelists for participating today and for sharing your time and expertise at this year's event. We hope everyone who tuned in will walk away from these discussions with at least one new idea that they can implement in their efforts to improve care for those living with sickle cell disease. We encourage you to spend time on the event platform to connect with others and explore event materials. Again, thank you all, and a big thank you to the Sickle Cells team, and have a great rest of your day.